some meaningful publications that can develop and build our department. So thank you all for attending. Thank you all for the residents who are here, who have answered the call to present this afternoon. And most importantly, I'd like to introduce and welcome our head of department, Professor Aiken. Also our judges this afternoon, Professor Marvin Reed, who is our acting deputy principal and deputy dean of research, Professor Maxine Gossel-Williams, deputy dean of graduate studies, and Professor Monica Asnani, head and director of the sickle cell unit. We also like to thank our sponsor, Ms. Karen Kelly from Ferrin. Will be streamed, but I hope more persons will attend in person as we go along. The program is pretty clear. Just for you as presenters, just a reminder, you are allowed 10 minutes to present. We're going to try and stick to the time. We have a timer today, and she'll tell you when it's 5 minutes, when it's a minute, and when you're out of time. So please stick to the time. You'll be allowed 2 minutes for question and answers, and I hope we'll be able to entertain questions from persons online as well. All right, we thank the support staff of MITS who is here also. And at the end, you will be judged as you present, and at the end, we will announce the best overall presenter. So stick around for that, all right? So without further ado, we're gonna start. I'm gonna invite Dr. Alfred Duncan from ENT to present on the clinical assessment of foreign body ingestions experienced in a developing country.
Ladies and gentlemen, good afternoon. My name is Dr. Alfred Duncan. I'd like to thank the organizers of this venerable conference for the privilege to present my original research paper entitled Foreign Body Ingestions, a prospective study of the Jamaican experience at 2 urban hospitals. So foreign body ingestions are common emergencies that are faced by otolaryngologists worldwide. However, there is actually a paucity of published data which examines the predictive value of specific historical and clinical examination findings that we routinely use in the assessment of patients. Therefore, it was our aim, our primary objective, to quantify the degree to which specific clinical and radiological findings are able to predict the presence of actively impacted foreign bodies within the pharynx and esophagus, and as a secondary objective, to describe the demographic characteristics of these patients. And so the research team had developed a multi-institutional prospective study spanning 2 years with patients that were included from the Kingston Public Hospital and the University Hospital of the West Indies, Mona, with a diagnosis of foreign body ingestions. We included all patients with an acute presentation, and we excluded those patients who were less than 12 years of age, participants who had complete resolution of symptoms with a normal lateral soft tissue neck and chest x-ray at the time of assessment, and we excluded patients who had symptoms which persisted beyond 14 days of duration with an absence of any supporting clinical radiological features. Each patient was assessed thoroughly with a telescopic laryngoscopy, lateral soft tissue neck, and chest x-ray. Patients with low index of suspicion clinically were subjected to serial clinical examinations, close observation, and were assessed with a trial of diet. Those who passed the trial of diet were discharged from the hospital and were followed up 1 week later with a telephone consultation. High-risk patients were subjected to direct laryngoscopy and rigid esophagoscopy under general anesthesia. Positive explorations, we had removed the foreign body in those cases, and for negative explorations, they were again given a trial of diet. If they had passed the diet, discharged with a follow-up call, and if they had failed the diet, then they were reassessed with a CT scan of the neck or a possible recourse for general anesthesia examination. So what were our results? There were 149 patients that were enrolled in this study. 90 patients, or just about 63%, were female, and there were 59 male patients. Most of our cohort came from the Kingston Public Hospital, responsible for 60% of patients, and UWI responsible for 39% of patients. Fish bones, interestingly, were the most commonly impacted foreign bodies within our study and are responsible for 60% of the total cohort. Chicken bones were seen less frequently, with numerically 32 historical presentations of chicken bones. History of dentures ingestion, less frequently at 9. And there were some miscellaneous foreign bodies related to pieces of plastic that were infrequently observed. As it pertains to pharyngeal ingestions, which were assessed using a telescopic laryngoscopy, the foreign body positive pickup rate in our study was 30.9%. Only 46 patients of 149 actually had an impacted pharyngeal foreign body. The oropharynx was the most common subsite that was the foreign body impacted. And specifically at the level of the tonsils, there were 15. Tongue base was 9. So we can see the tonsils actually are a very important subsite for assessment with these patients. As it pertains to rigid esophagoscopy outcomes, 22 of the 37 rigid esophagoscopies were significant for an impacted foreign body, with the upper third of the esophagus being the site of most common impaction in 77% of cases. So we performed that initial univariate analysis, but we took a step further to perform a multivariate analysis to look at which clinical findings in the history and examination correlated the best. And this was one of the ways that we were able to remove or reduce the impact of confounding variables. So we had found 4 clinically significant factors to mention here. Firstly, persistent patterns of discomfort were associated with pharyngeal foreign body impaction with an odds ratio of 6.8. Statistical significance achieved there with 0.003. Next variable being anatomical level of discomfort localized to the level of the cricoid cartilage or above. Fishbone foreign body ingestion history with an odds ratio of 57.2 with a statistical significance of 0.001. And also the timing of sensation localized during the meal as compared to after the meal. As it pertains to clinical findings which correlated to an esophageal foreign body, we could see that there was only a paucity of findings, really just 2, namely persistent pattern of discomfort with an odds ratio of 16.1 and fishbone ingestion, and a fishbone history of 11.7. So we can see that based on our data, we actually had a very high negative exploration rate of rigid esophagoscopies of 40.5%. And this is in keeping with international data on this subject, which ranges between 22% to as high as 76%. So we have found quite a large number of clinically significant variables, which statistically have been shown by our study, to link with an intraoperative finding of a pharyngeal foreign body. However, there are positive findings relating to esophageal foreign body impaction. And the research team were a bit puzzled by this, but we can only postulate that there might be an anatomical explanation. Firstly, the variation in the nervous innervation between the pharynx and the esophagus, whereby the proximal pharynx and the proximal esophagus especially receive their innervations from branches of the vagus nerve, pharyngeal plexus, and there are quite extensive ramification of these nerve branches with branches that communicate extensively at the level of the submucosa and mucosa. And this might be responsible for perception of pain, pressure sensation, which is more accurately localized as compared to the thoracic esophageal innervation, which is predominantly autonomic. Now, our study does have some limitations despite our best efforts. Firstly, we did have a small sample size of only 149 patients. Secondarily, there were some cases of missed data within our study, despite us trying to follow up with the questionnaires. And thirdly, there were some logistical challenges related to the short follow-up of patients as a result of the COVID-19 pandemic. But despite these limitations, we are able to draw a number of statistically validated conclusions. Firstly, that fishbones are the most commonly ingested foreign bodies within our setting. Secondarily, the oropharyngeal region especially, and the proximal third of the esophagus are the most commonly impacted sites. And this should really influence our clinical management to ensure that in each case of a presentation of an ingested foreign body, special attention is paid to these subsites. Thirdly, with respect to the clinical findings that have been demonstrated by this study to most accurately link with an intraoperative finding of a pharyngeal foreign body, these include persistent pattern of discomfort, a perceived anatomical location of the discomfort at or above the level of the cricoid cartilage. Thirdly, a perception of the sensation during the meal. As it pertains to esophageal foreign body impaction, certainly the presence of a persistent foreign body sensation, as well as presence of a foreign body shadow that has been identified. Now, these are our references. I'd like to share this study has been published. We'd like to thank the contributors for this study, without whose hard work it would not have come to fruition. And this is conclusion of phase 1 of this study. Looking to phase 2, we're trying to evaluate and see if we can build on this study to develop a predictive scoring tool to assist us in more accurate assessment of patients with foreign body based on their clinical presentations. I'd like to thank the audience for their attention.
Thank you very much, Dr. Duncan. Are there any questions for Dr. Duncan? Professor Reed? Absolutely, yes.
Correlation and association. So with respect to correlation, it's my understanding is that it's a type of relationship that has been statistically proven, whilst an association probably is less robust in terms of its relationship. That would be the best answer I can give at this time.
The next thing is that your N for your...
Can you repeat the first part? The next thing is your...
I'm sorry? No, the second part.
Yes, sir.
Your N was 103, out of 149, but you express your prevalence ratios and all of those things out of 149. Any particular reasons for that?
So I can just repeat the very first part of the question.
So you N for your modeling, for your predictive modeling, for you to detect your association.
Right.
You had an N of 103, yet for your prevalence estimate, you put it over 149. Any particular reasons for that?
Well, there were some cases of missed collection of data that might have influenced that particular statistical finding. There were a total of 149 patients, however, that were enrolled in the study. And each of those patients, as I said, had received their algorithmic management, as I had described. So that's the best answer I can give at this time, sir, to be honest. Thank you.
So can I just ask a question? So you said it was a prospective study, but you had missing data. Can you explain that?
So the means by which we had performed the statistical analysis and actually the collection of data was by us giving questionnaires. This was done over a 2-year period. Some questionnaires were lost. There were some cases where we had received the questionnaires, but not all the data has been appropriately filled out for each of the questions that were answered. So as said before, that is a limitation of the study, despite our best efforts. Another limitation I could also say was that not every patient that we wanted to follow up, we were able to follow them up appropriately. We attempted to call all patients who we had assessed or had a high risk of suspicion of a foreign body, especially for negative explorations. Some patients were not available to telephone follow-up.
So the follow-up, so you followed them up after they had it?
So
what happened? So the first thing I want to know is,
Sure.
this algorithmic management plan that you had, is that something standard and described in your literature, or is that something you novelly were doing for the center for the purpose of the study?
So this is something that's fairly standard in our management.
So everybody involved knew that this is how we
Yes,
should manage the patient?
that's correct.
So once a patient came in, they were consented and enrolled for the study?
That is correct. They were consented. We had to
And
get...
were they followed up after, or they were just seen just for that one time?
So it was our intention to follow up all patients who had been discharged.
Yeah.
Patients who had a positive foreign body that was removed,
Yeah.
we didn't really follow those patients. But for
Okay.
patients who had a high suspicion of a foreign body, but we did not see anything,
Yeah.
but they passed the trial of diet, these patients, we wanted to just make extra certain that they have resumed their diet, they have no lingering
call them
sensation
and
of pain.
you were
It was
able
our
to call them.
intention to call them. Unfortunately, not everybody was available for follow-up, despite our best
So
efforts.
my question, and the judges are here, is this a prospective study, or is it really a cross-sectional study? Or is that split in here? It feels cross-sectional, yeah.
Okay.
The issue is that it would have been better when you had that diagram that says your management plan. What you really need in terms of our thing is what we call a stroke diagram, which says these are the people that are eligible. These are the people that we followed or completed the study. These are the people who are missing because of A, B, and C. That's an important element in any form of studies where you're going to enroll, and your numbers are not going to be the same for the analytical data set.
Thank you very much for your input, sir.
I have a question. background, it would have been interesting to find out how, what actually led you to this project, but that's fine. I noticed that in your discussion, you actually referenced back to the literature, which was good. I'm not sure I saw anything on your secondary objective one, and I was just curious about your method of determining discomfort. What instrument did you use for that?
So there are several pieces of historical data which we utilize. Sensation of a sharp sticking pain. That is very nebulous in terms of we have to be so careful in assessing patients with foreign bodies because there can be subtle perceptions that may not be clear to the patient and that might mislead in one direction or another. So we look at multiple pieces of historical information, examination, and radiological findings, namely sharp sticking pain, soreness or discomfort. Those are the most common means. Sorry.
How do you measure, how do you quantify discomfort and we're able to describe it as persistent versus intermittent?
So a persistent symptom of pain is one that is constant and unremitting in nature with no resolution. We really classified it as for a minimum of I would say 3 to 5 days, if that is the duration of time where they had presented. So within that maybe they presented within 24 hours or up to 3 days of presentation, they have had no relief of their symptoms. But if patients who have an intermittent sensation whereby they have a period of pain, the pain reduces, and it's associated again with a further increase in the pain without ever reaching a normal baseline, we would diagnose that as an intermittent type of pattern of pain. And our studies have demonstrated that the persistent type seems to be more strongly associated with an impacted foreign body.
And is that established scale?
I don't think that's established per se as it pertains to specific foreign body ingestion because there's just not a lot of published data looking at the historical assessment. But we think that there was some value in the study to more clearly elucidate these relationships between history and identifying a foreign body. We may not have access to CT scans as often as we want, as regularly as we want, so we have to rely upon clinical assessment to assist us in making our diagnosis. And this is the completion of phase 1 of the study, but phase 2 will be taking this a little further to try to develop more robust means of assessment with a scoring tool in the future. Okay, thank you for your time.
Thank you. Thank you, Dr. Duncan, for your wonderful work. We're going to invite Dr. Jones. Dr. Jones is a resident in plastic surgery. He's going to be presenting on the reported outcomes of breast reduction surgery in non-Caucasian population.
Hello, good afternoon. My name is Javier Jones. I'm a resident on the Plastic and Reconstructive Surgery Service of the University Hospital of the West Indies. And here today, I'm bringing to you our study that I pioneered, essentially assessing the reported outcomes of patients who undergo breast reductions or reduction mammoplasties in our non-Caucasian population. So as a little bit of background, macromastia is defined by medical insurance purposes as enlarged breast tissue greater than that of 500 grams. And locally, reduction mammoplasties have been offered by our surgeons since as early as the 1960s. There's generally very little documentation or enrollment of this topic in the medical literature. And as a consequence of that, very few patients are actually offered surgical intervention despite their symptoms. They present with not just physical symptoms, but psychosocial issues as it relates to both body image and even the availability of appropriate clothing and limiting hobbies. A study done by Drs. Venugopal and Arscott in 2003 identified that those 4 top symptoms which patients may present as seen on the system there, over 50% of those patients have at least those. So our goals as it relates to surgery is to improve those symptoms and at the same time maintain an aesthetic mound, recreate or maintain rather a sensate nipple areola complex, improve the ptosis that's commonly associated with this condition, as well as limit scars. So we begin first with parenchymal excision, which essentially keeps vascular breast tissue based either superiorly or superior medially and inferiorly. We redrape the skin, utilizing standard surgical patterns such as the Y's, which is fairly reproducible, or a short vertical scar, and then finally repositioning the nipple and areola complex. To maintain sensation, we try to maintain vascularity by preserving that dermal pedicle to get the outcome as you can see here. Internationally, across the board, there is quite a bit of literature that states that the quality of life post-surgical intervention for those patients with symptomatic macromastia is significant. And there are several scoring systems which exist for the purposes of doing that. We opted to utilize one such scoring system, which is the BreastQ questionnaire, for our surgical evaluation. So the aim of our paper was to evaluate the quality of life changes that the patients that we have cared for over a 15-year period thus far at the University Hospital, utilizing the BreastQ tool. And as an adjunct, we hypothesized that with increasing surgical resection volumes, global satisfaction rates may also increase. With completing this, we would have documented the first objective quality of life assessment of patients undergoing non-oncological breast augmentation procedures locally. Finally, as the last piece of information for you guys, the BreastQ tool was designed in 2017, and it utilizes several Likert scale questionnaires which have been externally validated, and it's broken down into a few modules, including psychosocial, sexual, and physical components, as well as aspects that allow for service quality audits as it relates to the perception and quality of care offered by both service surgeons as well as allied healthcare members. So our methods were as follows. We identified those patients over the previous 15-year period who underwent surgery with a diagnosis of symptomatic macromastia. After consenting these patients in our outpatient department, we evaluated them utilizing the BreastQ questionnaire twice, estimating their scores prior to our surgical intervention and as they were now. And after completing that, we went through further docket review to identify and collect pertinent demographic data. We excluded patients who were also undergoing known oncological procedures at that time, those who underwent unilateral reduction mammoplasties or symmetrizing procedures, those who refused to consent, and in cases where there was incomplete or inappropriate documentation. The patients who fit this criteria was 16 in total, with a mean age of 33 years, spanning between 14 and 56. Our resection weights were from a low of 460 grams to a high of 1,900 grams, and a mean of 900 and almost 950 grams as a mean. This is significant, as majority of the international literature will state that resection weights for symptomatic macromastia generally lies roughly about 600 to 700. So we are tackling significant larger cases than the standard cases published internationally. As it relates to the findings after completing our pre and post BreastQ questionnaires, we have identified 3 specific components that we wish to share with you today. We did that utilizing our box and whisker plots to give you an idea of the change in the means and quartiles for this group. As you can see across the board, there was significant improvement in the quality of the scores after surgical intervention across all 3 groups, with a significant jump in our satisfaction. We went further to test our hypothesis utilizing a scatter plot. And as you can see, our line didn't necessarily follow exactly our hypothesis. In fact, we got closer to a null scatter plot hypothesis than a positive correlation. And our hypothesis or inferences is that with increasing surgical size, the difficulty of the procedure increases, and so too the potential complications that these patients may face. In the medical literature in our noted international medical literature, The incidence of surgical site infections is as high as 15 to 20% in patients undergoing reduction mammoplasties. And furthermore, we postulate that these patients with higher resection volumes are more likely to have some of these symptoms and hence a globally reduced satisfaction score. So in conclusion, there was significant improvement across the board, including satisfaction. However, there was no significant correlation between satisfaction scores as well as our resection volumes and the potential reason as I outlined before. And again, there was significant quality of life changes across all subgroups utilizing this tool. Our limitations were that it was a fairly small study based on the availability of surgical time as well as surgical trainees involved in the care for these patients. We hope that with time, as more residents are involved in the process, that we too can increase our numbers and take this study even further. Additionally, given its retrospective nature, it may limit the efficacy of the utilization of the BreastQ tool. It was based out of a single institution, and in some cases, we lost because of documentation issues. So in moving forward, as I alluded to, the aim is to have a robust prospective review of these patients and assess their quality of life changes moving forward, and also to assess if this surgical intervention has any impact on potential chronic comorbidities and even respiratory function. It allows for continued clinical audits to help improve and maintain the care that we offer to our patients, and to pilot further studies as it relates to non-oncological breast augmentation studies. As I made mention to you guys earlier, within our medical literature, there is limited documentation and inclusion of this aspect in our curriculum. So this is another area of potential study that we can utilize to revamp our medical school literature and curriculum. Here are my references. Thank you. Any questions?
Thank you, Dr. Jones, and thank you for sticking to time. Are there any, Dr. Blijan?
If you have a patient that weighs, let's say, 150 pounds, how do you know that 980 grams would be adequate to achieve that satisfaction for the patient?
Okay. So as it relates to our intraoperative decision-making, choosing when to stop essentially, first of all, we must do no harm. So a safe resection is everything. We design our pedicles based on the estimated starting weight, and from there, we can estimate what we can safely take off thereafter. There's no mathematical equation per se to calculate exactly how much we can take off, but as it relates to what we safely can do, once you start going above once you start going above that 1,000 grams, it becomes increasingly technically challenging, and some people may not even offer in other institutions that as a routine procedure. Yes, sir.
Because at the end of the day, I think the most important one is the psychosocial and the quality of life of the individual.
Correct.
Right.
So we try to meet the patient, we try to temper expectations and have a robust discussion with the patients prior to even reaching the operating theater room. So while, yes, it is important and some of them may be desirous of attaining a significantly smaller cup, we also in our consent and counseling explain to them just how much is safe and what we can truly offer.
Professor.
All right, so what was the average time between the pre and the post questionnaire? I didn't get that.
Right, so as I was explaining, this is unfortunately retrospective in nature, and this is why we want to go ahead to proceed to a prospective review. We saw these patients, they're all technically post-surgical intervention, and it's estimations of their BreastQ scores from their initial presentation. So it's all highly subjective, it is all highly limited as it relates to how, correct. Yes, there may be some element of bias, as Dr. Marcin Blijan was, you look confused.
Didn't do the
So-
questionnaire before the surgery? And
No, correct. So this is the first time any form of documentation as it relates to this literature is here, and hence the pilot nature of it. What we did is that we had that discussion with the patient. We estimated, utilizing the scores, what their score preoperatively would have been, and then went on to do the questionnaires immediately. As it relates to the patients moving forward, our plan is to, on initial consultation, have a breast Q score done for all patients, and then at standard intervals post-operatively, at first at 6 weeks, and following that at a year post-surgery to do subsequent breast Q interviews.
So that means that box and whisker is pure nonsense. All right?
No problem.
Because it has nothing to do with what the patients actually did. The only other question I wanted to ask you, in your definition of macromastic,
Yes, sir.
you had a 500-gram limit, but in your patients, you have a range of 460 to 900 and something.
Right,
So
so-
that 460 person would not meet your qualification as a macromastic.
So those numbers are all for one single specimen, meaning to say that the left, for example, could have been 460, the right in that patient, probably a slightly heavier, would have fell into the 500, sir. So by definition, sure, that single case from the study would not meet the strict definition on the left, but the contralateral side, which very often is, there's usually some asymmetry between the sides, very often falls above.
So it could also fall below.
That's also true, sir. But the lowest number, as I said, sir, was 460, the single outlier, if you will.
So hi, Dr. Jones, thanks so much. I read your abstract as well, and I was waiting for clarity on your presentation, but I think you've answered Prof. Reed. So what you actually did, I think anytime you're presenting a research study, there must be clarity through your abstract and through your presentation as to what actually was done. We should not be left confused. So what you actually did is looked back at the dockets, everybody who had this reduction surgery, and then you called them.
So yes, these patients are all patients that we see routinely in our outpatient department. So we contacted them, brought them back in for the purposes of getting a starting point, albeit biased. We applied the breast Q to estimate what their scores would have been before, and as they were now sitting in front of us, which would have been post-operatively.
I don't think you presented. So one woman could have been 1 year post-reduction and another could have been 14 years post-reduction. Did you present that data?
So, right, these patients are over a 15-year span, and the issue in this case is that literature is very limited, and we have,
But you can actually say that I had surgery a year ago and he had surgery 3 years ago and she had surgery. You would have that in your dockets, wouldn't you?
well, from interview. So, okay, I follow you. So, majority of these cases, I don't have the information directly on hand, but majority of these cases were interviewed maybe about 7 to 8 years post-surgical intervention. 15 years prior, the number of cases were limited based on the availability and the presence of the surgeon at that time.
The surgeons that were involved, if in all your cases, was it the same surgical team? And I'm asking that because it seems that there's quite a bit of subjectivity in terms of the volume that's removed and whether you consider that in your analysis.
So, as it relates to the surgeons, it's 2 primary surgeons across the board as main surgeons with us residents as assistants. But the primary surgeons have been 2 throughout the years.
So you told us that we included everybody for various reasons. We didn't have information. It's not because of cancer, etc. So you got 14.
16.
What was because 16 is 14 years.
Sure. So if you include all patients who underwent breast augmentation procedures, the numbers would have gone significantly into the 50s, even higher. But the issue is, because of the impact of oncology and the aspect of this condition, we opted to exclude those patients for the purposes of analysis. And those cases who underwent unilateral reductions, for example, that would be a patient who would have had a mastectomy prior, for example, and wished for some reduction on the side for a little better, for better balance. Those patients were also excluded because it would affect or bias the results that we get.
That's fine. One last question.
Yes, sir.
The breast cube, you spoke about it being validated. Validated in who?
Right. So there is medical literature arising from multiple populations of different Fitzpatrick skin type patients, which show that it is a useful tool for identifying these purposes, right? This specific tool over others, how its modular design is what was the most attractive aspect of it. So it allowed us to not only do the necessary psychosocial, sexual, and physical assessment, but it also allowed a component where we too could audit ourselves and use that as a means of quality assurance and improvement, which some of the others may not have that aspect, sir.
Okay, we'll talk about it later.
You said it was done in a non-Caucasian population. So what? Why? What's the difference? Do black women have bigger breasts than non-black men? What's the purpose of mentioning that?
So it's referencing to our population, which is mixed,
So
sure.
all the patients here were non-Caucasian.
Yes.
All right, I think.
All right, thank you.
All right, thank you, Dr. Jones. Well done. All right, Dr. Dwayne Campbell will come next from neurosurgery as he speaks to us on spontaneous sinus blowout. He's gonna let him. No, come around. Man. He's gonna open it up for you.
Hi, good evening in the interim until the slide is up. I'm Dwayne Campbell. I'm fourth-year resident in neurosurgery currently, Firm B. Just here to speak up. You said wait? Oh, hi again, I'm Dwayne Campbell, a fourth-year resident in neurosurgery on Dr. Bruce's team, Firm B. Just here to speak about an interesting case that we found. How do I skip the slide? Thanks. Which is on spontaneous sinus blowout. We chose this topic, really, because leading up to the workup for this patient, it was quite a diagnostic dilemma involving both our institution and another type A hospital, and a multidisciplinary team meeting had taken place, which also provided some amount of difficulty. So just to get into the case, the history and exam is a 38-year-old female with a history of chronic hypertension, chronic sinusitis. She had new onset headache for about a year, 7 out of 10 in intensity, with no change in the intensity or the frequency since its onset. Did not relieve with over-the-counter analgesics and denies any trauma associated with this onset of headache. She had presented to a peripheral institution at this time where diagnostic investigations were done, and she was subsequently referred to us for a potential arteriovascular malformation in the frontal lobe of the left frontal lobe, sorry. Her examination at the time, she had a right hemiparesis for 6 months, she noted, just to add that to the history. She had left ptosis, but her pupils were equally reactive to light at 3 millimeters direct and consensual, and she also was limping. The investigations that she was sent with. She had a CT that was done. CT showed an ethmoid defect with calcification within the frontal lobe. This was in the early part of 2023. She went on to have a CT angiogram and an MRA, and this was because at that time they were querying if this hyperdense lesion seen on CT could have been a possible nidus. What that angiogram, or those angiograms shows, was a loculated pneumocephaly involving the frontal lobe, lateral horn on the left side, and also abnormal vasculature surrounding, same with dilated cortical veins. Now, this is interesting because the patient was actually about to receive surgery when these findings were noted, and said surgery had to be postponed. This patient was subsequently referred to neurosurgery at this point, where a digital subtraction angiogram was performed, same revealing no vascular malformation. The preceding slides is really just to show that investigations. So if you're seeing the pointer, the mouse, are you? Not sure why. But this was to simply show on the top right that the left maxillary sinus has a fluid level in CM, and moving one slide over, that middle upper shows that on the left side, if you look very keenly, you can see there's a fluid level also on the left middle anterior ethmoid. And moving further left, in the upper aspect, there's a defect involving close to the medial orbital wall. Oh, sorry. So this was just to reiterate, maxillary with air fluid level. Right here, when I remove the pointer, you will see the air fluid level to the ethmoid at the left, anterior just the same. Further over, right here, there's almost an air fluid level, which is really that defect in the ethmoid that we're seeing at the medial aspect of the orbital wall. And in the images below, it's really showing bony windows of the cranium. On the left image, it's a bony defect, and that black, when I remove the pointer, you will see that's air next to the bone. And moving to the image over is just to get a better look at that intracranial portion of the bone. Here, so this gray, right here where the pointer is the fluid, and this black above the where the pointer is air. Apologies, my apologies. I'm not with an eye of faith and some trust. Right. So just to show, this is really, it's probably showing black for you again, all black. But it was really just to show that intracranial component where there was a loculation of the left lateral ventricle. And this is the MRI of same, which had shown air. This is showing black and gray? Yes. So this is the air, this is air. Here, when I remove the pointer, that's the bone elevating into the brain. Now here is air, this gray is fluid, right, within the ventricle, and this is air also anterior. So that's that loculated air that they were speaking of initially. And to the other side, this hypo-intense area, 5 minutes, thank you, is the bone. And this is the angiogram, which confirms no vascular abnormality, as was said previously. So our assessment at this time was a spontaneous sinus blowout with pneumocephaly. Plan was to have a craniotomy with anterior skull base repair, and to discuss as a multidisciplinary team whether the consideration for an endonasal endoscopic approach could be done as opposed to non-operative management for this patient. We had decided on operative management both because the patient was symptomatic, having neurology, and it was large volume and loculated, and the patient was still having intense headache for over a year now. So our findings was, as seen on the right, where the pointer is, was really mucus-like membrane, or mucotide membrane, epithelium, right, with bony fragment that was found intracranial and also associated with the brain. And on the left, this is right here where the star is, that's the bulging of the ethmoid mucosa through that bony defect that exists right here at the pointer. And this arrow is pointing at the bone that was removed from the intracranial portion. And this is just a better detailed picture of our intra-op findings with this being our bony defect. I know it looks very rounded, but when you see the histology, you'll understand why it is rounded. And this is the bone that was removed. Post-operative imaging, this is her actual post-op imaging. What's seen right here in the hypodense, mixed density area is really just that fat pad graft that was taken from the anterior abdominal wall in aid of closing that anterior floor defect. And these are her other post-op imaging. This you can see there's a small volume of air remaining, which is okay, that will resolve over time and with oxygen. And of note, looking back at the left maxillary antrum, there is no more fluid level within, same. And this far image on the right is showing our split calvarial graft, which was used to cover the ethmoid defect. Post-operative, she did well, and she's now in the outpatient clinic. Her histology. What it showed was we had 3 samples. So the first, the ethmoid sinus bone, showed fibrocollagenous connective tissue covered with respiratory epithelia, scattered lymphocytes, neutrophils, and mast cells, with also neural elements having glial cells present the same, and congested vascular elements as well. Other tissues shows, again, respiratory mucosa and vascular congestion along with inflammation, lymphocytic tissues invading, same. And for the sinonasal component, again, it was similar to the prior. And of note, you see there's occasional osteoblasts and osteoclasts, which shows why the defect was remodeled to having such a rounded area. So our discussion really is about nasoethmoidal fractures, typically associated with trauma, but in this case, it was associated with a violent sneeze, as first described by Richter and Gallagher, where a patient with chronic sinusitis developed a left forward type 1 fracture. So spontaneous pneumocephaly is often associated with an unknown pathophysiology, but sometimes may involve a fistula that links to the mastoid ear cells or frontal pneumatoceles. Typically, pneumocephaly is secondary to treatment treated conservatively and secondary to trauma. Insufficiency fractures, however, should likely to occur within bones that are undergoing pathological processes, which impairs their ability to either withstand the shear force that they should or to withstand any amount of exertion. However, in non-weight-bearing bone, right, while it's not a matter of withstanding the exertion, it's simply just to withstand the pressure that transmits through, same, 1 minute remain, right? And we theorize that this may be accounted for, considering Laplace rule, where the wall tension increases as the pressure increases. And just to note that line, where a sneeze generates about 1 psi, which is about 7,000 times the pressure of gravity. So it helps us to understand why, even though such a small radial area, that is the ethmoid sinus, may have a defect, or why the force exerted on the walls would have been so high. And histology, again, showing that inflammatory cells, which is in keeping what we'd see in someone with chronic sinusitis, and the osteolytic activity helps in showing us why there was remodeling of that bony defect that would have been present. So just to point out, currently, there's no guideline for the management of spontaneous pneumocephaly. However, once a patient is symptomatic, then they should be treated. And sinusitis is not benign. And I'm out of time. That is it, by the way. Hi.
But I wanted to break it down for me. I don't know why Dr. Morrison has invited a GP to this August set of presentations, versus not even gen search, right? It's all kind of highfalutin thing. But what I picked up from both the abstract and your presentation, just tell me if I'm correct, is that this 30-something-year-old very young woman presented with a 6-month history of left hemiparesis.
Yes.
She just didn't present before that, or
No, she was, yes, not to us, but she was seen elsewhere.
What came to pass through all of these exciting investigations is that she probably had chronic sinusitis, yes, and as a result probably of a violent sneeze, displaced or had a fracture of the ethmoid sinus, and that led to all that development of all that pathology in the brain.
Yes.
Am I correct?
Yes, you are.
It's definitely a very exciting case for a GP even to figure out what's causing a stroke in a young woman. Did she improve?
She did. She's ambulant. Her only persistent symptoms at this time is seizures, which is controlled with Keppra.
So you mean she has regained full?
She has.
Excellent, excellent. So it is exciting. I figured it out right, and you did very well. Only thing is that, I don't know where you want to publish this, because it must get published. I'm sure it's a weird enough case to be published. Is that it should be so presented that it's easy enough to understand by all your readership.
Understood. Thank you.
A few quick things to assist you in your publication. Are you familiar with the Twitter Network Care Guidelines?
No, sir.
Care Guidelines. You're going to need to read it if you want to publish it. The second thing now is in one sentence, because that's what you're going to have to be focusing on when you write it down. What is special about this case?
It has not been described before. The fractures, when you look through the literature, what's really described is orbital wall fractures, bloats, as in sinus blowout fractures, or failure of the roof of the maxilla with enophthalmosis of the eye. But for a fracture of the ethmoid, because it's the higher sinus and most of the volume of air being expired is really through the maxilla and the frontal sinus, it's really not something that has been documented.
Why do you think it's due to a sneeze?
Why do I think it's due to a sneeze? Well, looking at the histology, she has a lot of inflammatory cells. We have herniation of the mucosa into the brain, which says the pressure is coming from below. And she's known to have chronic sinusitis. The only other explanation is God, sir, or a cough. A cough also generates the same amount of force, which she could have coughed at any point, either from, choking or just clearing her throat or anything.
I noticed the way you presented, you presented CT angiogram, you presented digital subtraction, and then you go to the MRI. Why did you do that? In the sense that if the patient presented with evidence of hemiparesis, severe pain, why don't you just go to the MRI first to get all that information? Because it seems to me that in terms of investigation, you still end up at the point at which you should end up anyway with the MRI.
So the MRI was actually done as a preoperative planning to use in our brain lab. However, what happened was the CT was done, because how she presented sounds like a stroke, so you need to rule that out, which is why the CT was done. And that hyperdensity would says, hey, possibly this is an AVM. So they did get an MRI, which is a MRA also has an MRI to it. So they did get an MRI and a CT at that point. And then they got a digital subtraction angiogram. But the MRI that you're talking about was simply for preoperative planning, because her images by then was near 1 year old. The MRI, 1 year. She had hemiparesis for 6 months, but she had headaches for 1 year. So she started her workup in the periphery for 1 year, but came to us in October, which was like 9 months, 8 months into her issues.
Which is why you have to read the care guidelines.
Yes, sir.
Yes, it can be.
Understood. Well done. Understood. Well done. Thank you.
All right, wonderful. Wonderful. And someone who needs no introduction, Dr. Seaman from CTH will present on perioperative mortality of cabbage at the University Hospital. Just let him come in.
Good afternoon, everyone. Good afternoon, everyone. I am Gavin Seaman, resident in cardiothoracic surgery. And today I just wanted to point out some data we've been collecting. It's on perioperative mortality of coronary artery bypass grafting at the University Hospital of the West Indies. And this will be from 2018 to 2023. So this is just a preliminary report. The data is still being collected. So according to the WHO, ischemic heart disease is the third leading cause of death in Jamaica, and in 2019 accounted for 61.3 and 55.8 deaths per 100,000 men and women respectively. Coronary artery bypass grafting has become an important treatment modality for many patients suffering from ischemic heart disease, aiming to both relieve symptoms and to prolong life. The CABG is complex and resource intensive. An analysis of outcomes is necessary for quality control and for improved results. Cardiac surgery is traditionally known to have higher perioperative risk than most other specialties, with many patient and systematic factors affecting mortality. The first detailed analysis of these factors done in Jamaica was done by Macau et al. In 2016, and that will be used as a benchmark for comparison, along with studies from other developing and developed countries. The objective of this study is to establish the perioperative mortality as within 30 days of surgery of patients undergoing CABG at the University Hospital in Kingston, Jamaica, between January 1st, 2018 and December 31st, 2023. These include emergency, urgent, and elective cases. A secondary objective is to identify the factors that may contribute to the increased mortality. So this is a single-center retrospective analysis of all isolated CABG cases performed at UWI during the stated period. All cases were performed by local cardiothoracic surgeons and placed on cardiopulmonary bypass. Data is being collected from outpatient clinic records, operative theater notes and logs, patient files, and the hospital and National Registry of Births and Deaths. Information being gathered includes demographic data, the time between onset of symptoms and surgery, the number of affected and revascularized vessels, preoperative ejection fraction, the STS mortality risk score, the Euro score 2 mortality, intraoperative blood loss, rates of reoperation, post-op atrial fibrillation, surgical site infections, pneumonia, renal failure, sepsis, number of days after surgery that death occurred, and the cause of death. So perioperative mortality will be considered death that occurs within 30 days of skin incision. The STS score is the operative mortality estimate derived from the Society of Thoracic Surgeons Next Generation STS Short-Term Operative Risk Calculator, which is available online. And the Euro score 2 was created following a collaboration by researchers at Royal Papworth Hospital in Cambridge, in the United Kingdom, and the Centre Hospitalier Universitaire de Martinique, and predicts perioperative mortality. So these are the factors that are highlighted in calculating the STS score, including the type of surgery that's planned, whether it's their first or recurrent surgeries, whether it's emergency, urgency, or elective, the sex, age, height, weight, patient's race, and whether or not they're insured. Also the laboratory values like creatinine, hematocrit, white count, and their platelet counts. And then you have comorbidities like presence of diabetes, hypertension, liver disease, mediastinal radiation, if they have previous unresponsive states, dialysis, cancer, syncope, or immunocompromised, and other conditions like endocarditis, drug use, alcohol, tobacco. And then you have other pulmonary, vascular, and cardiac status parameters, as well as the degree of coronary artery disease, including how many vessels were affected and the proximity the vessels were affected in, and other cardiac parameters. The Euro score 2, which is similar but less detailed, does look at the age, surgical, biological sex, chronic lung disease, patients' poor mobility, whether or not they have renal impairment, and multiple other functions of their cardiac and respiratory systems. So data collection is currently ongoing. So far, 166 patients were identified undergoing CABG, of which 11 were excluded because they had concomitant valve procedures, and a total of 155 isolated CABG cases. One of those cases was a repeat coronary artery bypass grafting. 83 patients were treated publicly via the outpatient clinic, accident and emergency, and hospital wards, while 72 were treated privately via the Tony Thwaites wing. Of the 83 public cases, 69.9%, or 58 of them were male, and 30.1% were, or 25 were female. 27.7, or 23 of them had quadruple, and 49.4 had triple bypass. And our so far in collecting the 30-day mortality is noted at 14.5%, and that is 12 deaths within the stated time span. 4 of those deaths occurred by day 3, 5 by day 4 to 14, and 3 occurred from day 15 to 30. Mortality rate for men was 13.8% and 16% for women, which agrees with, well, correlates with international data that shows women are of a higher risk. No deaths occurred by 30 days in patients who were discharged. So all patients who were discharged survived the 30 days. Looking at it by year, from 2018, we had a 23% mortality of just 3 deaths. 2019, we had 3 deaths. In 2020, there were a lower number of cases done publicly, and as well as overall, due to the coronavirus, but no mortality were recorded on our public cases. We had 2 deaths in 2021, and 2 deaths in 2022, and same in 2023. As we have more cases, a lower in mortality rate. So ischemic heart disease remains one of the leading causes of mortality, and its prevalence is increasing with an aging population. CABG has become an instrumental in its management, and as such, improving perioperative outcomes is crucial. Globally, the perioperative mortality rates have decreased significantly since the first reported hand-sewn graft done by Sabiston in 1962, with current reported rates internationally of 1 to 3% in developed countries. A previous audit done by Scarlett et al. Showed a mortality of 21%, that's up to 2001 at the University Hospital. And a subsequent study done by Macau between 2010 and 2016 had showed a crude mortality of 8.4%. A study by Rich et al. In Johannesburg, South Africa, of 1,218 patients between 2000 and 2017 had a crude mortality of 11.2%. An analysis by Pierce et al. Of Brazil, where they went through their bypass registry, which is a national registry there. In 2019, of 2,292 cases, revealed a mortality of 2.8%. And that ranged from center to center, with 1.7% in one private hospital and 7.4% in a university hospital. A study in Trinidad and Tobago by Aguilini et al. Of 1,363 patients, with 99.5% of those being done off pump, undergo CABG from 2015 to 2019, and that was done at the public hospital, Eric Williams Medical Sciences Complex, and the private hospital is St. Clair Medical, and they had an in-hospital mortality of 0.8%. However, they did not report on a 30-day mortality. The authors of that report credited the drop in mortality, where they had previously reported 5% in 1999, to frequent, regular outside visits, training of a core group of individuals, complemented with training in a designated partner overseas center, and transfer of knowledge via that route. The high mortality of 14.5% noted in this study so far is just a preliminary result, and it's not accounting for all cases, and also includes emergency cases. So we still have more data to compile, with more cases not yet accounted for. Completion of data collection and subgroup analysis is needed for interpretation and comparison with previous studies. Primary limitation so far of this study is the small sample size when we compare it to other studies. Another limitation is our unknown correlation of the STS and Euroscore 2 mortality predictions based on our populations. So multiple factors may contribute to the high perioperative mortality suggested by this data. And the ultimate goal of this study is to identify these factors and then therefore take steps to mitigate their effects. Thank you. And these are the references.
Dr. Seaman, Dr. Blidgen.
The presentation was just on the public side, right?
Yes, sir. Well, still have to accumulate all the data from private.
Right, but the point is that you have 160-something numbers, you said 70 was for private.
Yes, sir.
Did you provide the private numbers and see if there's a difference in outcome?
Pardon me? I didn't hear the last.
Did you look at the private number?
No, I haven't gotten around to that yet. That's still being compiled.
And then the second thing I wanted to ask you, because at the end you identified that it was a lump sum of patient concerns, emergencies and all of those things. So did you identify the effect, ejection fraction?
So that is being compiled as well. So all the data is not completed in collecting.
So you've been...
I have a few questions for you. I recognize that you say you're not finished, all right? But a couple of quick things. The first is, you said that you're going to be looking at some funny scores here, some STS score and some Euro scores. All right?
Yes.
That's what you said?
Yes.
And you're going to use those scores to do what?
So we use those scores to predict mortality, and you also predict.
You're going to use them as a predictive scores for mortality in your sample. How do you plan to do that?
So you compile the data, so all the information that's necessary, collect
Yes,
data,
you have the data.
we
So how are you going
calculate
to do
it,
that now?
and then we use it to compare the actual.
Or how are you going to do that?
So
Yeah.
we use those scores to help prognosticate patients. So it's really a preoperative use for the scores. But
Yeah,
what
but I
would
know
do
what
is-
you're going to be using it. How are you going to now get the score? What cutoff value are you going to get for the score? How are you going to go about getting that cutoff value?
So it gives you a percentage, whether the patient has a 1%, 2% risk of mortality perioperatively. Those are the results you get from the score.
Okay. So is the output from the algorithm that it is a number? Is it a number?
Yes, so it gives you a number of 1%, 2%, 3% risk of mortality.
All right.
And we can categorize them at low risk if they're less than 4%, intermediate 48%, and high risk greater than 8%.
Okay, so that's not really what
I
you're
just want to
doing.
explain.
Yeah.
Seaman, okay, the Euro score and the ST score, there's a lot of factors that we use. So we're talking about patient age, ejection fraction, and all of those things. When we all put together, the emergency surgery give us a score. And based on that number, we can discuss whether or not this is a patient. Well, we can prognosticate in terms of discussion, and sometimes we decide that, you know what, let's send this patient for PCI, percutaneous intervention, because open surgery have a higher mortality.
All right, so you see, it's not matching up with what he says in the study objectives and so on. So the issue is that on one hand, what I interpreted he wanted to use the score to do is that post-op, he has his data set. He wanted to then basically see, because that prediction score that you get from the STS is from some other population on the bottom. So I thought what he was going to tell me is that he was going to now ascertain what value of that score predicts the mortality or outcomes based on his data set.
Right, which is what we use it for. So we use this.
But in a retrospective way.
No, it's clearly a retrospective thing, but I'm just saying.
Okay.
That is what I was expecting him to be saying that is what he's going to do. Otherwise, the score means nothing.
Right.
I do my essence to collect it.
Right.
So that's question number one. And the process of doing that is you have a continuous variable that you're trying to find to predict a dichotomous variable, which is dead versus non-dead. You would do what is called a receiver operated characteristics analysis. All right, so that's fine. I understand you don't understand that. The next point of the matter is...
That's independent variables.
No, man. The next part of the matter is, in terms of your approach for the mortality now, the perinatal mortality, perioperative mortality, sorry. You are collecting the time at which they have surgery.
Right, so...
Right? You're collecting the time at which they have died.
Yes.
All right? Why not use time to event analysis to work out your mortality rate?
In terms of years. So we're looking at the 30-day mortality rate. And so we're looking at from the time that the patients have the operation to the time when death occurs. So I'm not exactly clear on the question.
So the short answer is that when you do a time to event analysis, it depends on what your eventual sample size turns out to be, but you may more likely to be able to determine the characteristics more efficiently because you're using time as a continuous variable, as opposed to saying you want people who have died in 30 days, right? Because in that case what you do is a category. All right, so that's all. You have that opportunity to do that approach.
Okay.
But I'll leave you.
Thank you.
How did you confirm that the persons who were discharged prior to 30 days had not died?
Through reviews of the records. So all those patients who were discharged were eventually reviewed back in the clinic. And so those records were reviewed. And all the patients have been accounted for.
So have you gone through the records so far?
Not completely.
Okay.
So,
Presentation, and I'm almost afraid to ask it since Prof. Reed hasn't asked it, Dr. Bridget hasn't, and none of the other surgeons have. Your outcome is what?
Death. So we're looking at mortality.
No, tell me from the title. Perioperative mortality within 30 days
of surgery.
What is perioperative mortality?
So,
how do you define this?
So patients who die from a skin incision to within 30 days.
Post-operative?
Well, it's a wrongly operative time.
Sorry?
It's a wrong for operative.
Do you still call it perioperative? I mean, perioperative, if you say within 30 days, I could say somebody died 2 days before surgery.
Well, true, but we're looking at it from skin incision. But
So
I guess
I'm not sure whether that's the correct term, even though I'm in the middle of surgeons. But be very definite about what you're talking.
But it could include
Is it
intraoperative.
during surgery
Could
and
include
post-surgery?
intraoperative as well.
Sorry?
Could include intraoperative, yes.
So intraoperative and, okay, so you still call that perioperative?
Yes.
I wasn't sure from the time I read that. And, okay, I know you have a lot of analysis to do, but I was really waiting to see. You've only done the public cases, so obviously we're waiting to see what the private cases look like. Probably worse, going by where your private case is coming from, but anyways, that's my own issues with Tony Twaits. You are not able to give us any idea of what are the factors that are showing associations with your death versus non-death?
It's not analyzed completely. I've noticed an association, a high association with mortality with patients who have preoperative renal failure and lower ejection fractions. But that has not been analyzed yet.
It's just early analysis. Okay. All right, thanks.
Thank you.
I would encourage Dr. Seaman to complete that data collection and analysis.
Thank you.
All right. Thank you. So gives me pleasure to introduce Dr. Lorian Vaz from Department of Division of Urology. Absolutely. Yes, come on now.
Okay, good evening, everyone. Thank you for the opportunity to share our experience from the Department of Urology. The infected obstructed kidney, we don't have that many emergencies in urology, but it's one of the few emergencies that we do have, which is why there's particular interest in these subset of patients. And just a bit of flashback to 2020, during the COVID-19 pandemic, when I'm sure most of us can relate that we had inevitable delays in getting patients into the operating theater. And I couldn't help but wonder, are we doing a disservice to these patients? Are they any worse off? Because the teaching in urology is that you should get these patients to the operating theater as soon as possible. And that led me to do my presentation on the ideal timing of decompression of the infected obstructed kidney due to a ureteric calculus is sooner always better. So nephrolithiasis is a very prevalent disease worldwide, not just in Jamaica. The lifetime risk is said to be anywhere between 5 to 10%. And the risk of recurrence is quite high. Up to 50% of patients will have a recurrence in 5 years. So this is quite a significant issue. Approximately 20% of patients with a ureteric stone will present with some form of complication, whether that be renal colic, renal impairment, or a superimposed infection. When there is infection associated with ureteral obstruction, that is termed as an infected obstructed kidney, and this is considered an emergency, as sepsis can lead to a mortality of up to 11% in these patients. So studies have shown that surgical decompression is associated with a reduction in mortality. However, up to 15% of patients still develop significant sepsis despite the decompression. Current guidelines by the American Urology Association and the European Urology Association advocate for prompt decompression of the infected obstructed kidney, but the ideal time has not been clearly elucidated. They just say prompt, whatever that means. This study seeks to evaluate the ideal time of decompression and the impact on patients' outcomes. So the aim of this study is to compare the outcome of patients with an infected obstructed kidney who received a DJ stent within 24 hours, considered immediate, 24 to 48 hours, urgent, and greater than 48 hours, delayed. So it was a retrospective study, and we examined the medical records for patients who received a DJ stent as an emergency between January 1st, 2011 to December 31st, 2020, so that's over a 10-year span. And patients were considered infected obstructed if they met 2 SIRS criteria in addition to a radiologically confirmed stone that's on CT scan or ultrasound. Patients were excluded if they presented with septic shock, because the standard of care for these patients is that they should receive a nephrostomy tube. If they had ureteroscopy at the time of DJ stent insertion, at the time of, or intraoperatively, they were excluded. If they were decompressed greater than 5 days from admission, or if they had coexisting inflammatory or infectious conditions, such as appendicitis, for example, which can happen. So these patients were divided into 3 groups based on the time from admission to urology to the time of decompression. This was less than 24 hours, 24 to 48, and greater than 48 hours. So the outcomes that were measured, the primary outcome was that of post-decompression sepsis, and this was defined by the QSOFA, or the Sequential Organ Failure Assessment Score, as greater than or equal to 2 parameters of the following: altered mental status, GCS of 14 or less, increased respiratory rate, equal or greater than or equal to 22, and a systolic blood pressure of less than 100 millimeters of mercury. The secondary outcomes that were looked at were intraoperative hypotension, that was defined as less than 100 millimeters of mercury. If there was intraoperative inotrope use, that be formal or informal inotrope use. If there were ICU consults or admissions, as well as the time to normalization of parameters, their temperature, pulse rate, blood pressure, as well as the white cell count, the length of hospital stay, and the readmission rates within 30 days. So 62 patients in all were included in the study. 30 patients were decompressed within 24 hours. 20 patients were decompressed 24 to 48 hours. And 20 patients were decompressed greater than 48 hours. There were no significant differences in the patient's age, gender, comorbidities, their baseline parameters, such as their vital signs and white cell count, and there were no differences, no statistical differences in their stone characteristics. The median time to decompression was 25 hours, and the overall rate of post-decompression sepsis was 16.8%. There was no statistical difference between the rate of post-decompression sepsis between the groups, albeit that there was quite a higher percentage in the less than 24-hour group, which is contrary to what we expected. This did not achieve statistical significance. So in terms of the secondary outcome, there were higher rates of intraoperative hypotension in those patients that were decompressed greater than 48 hours. And much to our surprise, the patients who were decompressed in less than 24 hours had a very high rate of intraoperative hypotension as well, and this was statistically significant. Once again, contrary to what we would have expected based on our long-standing teaching in urology. Decompression greater than 48 hours was associated with a longer length of hospital stay as expected, and there was no real difference in terms of hospital stay between less than 24 and 24 to 48 hours. In terms of the other outcomes, such as the use of inotropes, ICU admissions, there was a trend towards a higher rate in the less than 24-hour group, but this did not achieve statistical significance. Right, so those were the pertinent findings. So just a brief discussion. The first landmark study done by Borowski et al. In 2013, they were the first ones to document the importance of decompression in these patients. And they found that patients who were not decompressed had a mortality of up to 19%, and this went down to 8% with surgical decompression. In 2016, Blackwell et al. Further developed on that evidence to show that patients who were decompressed after 48 hours had a higher mortality rate, right? These patients, they described this as a weekend effect. So greater than 48 hours, that there is evidence to show that these patients do worse. To our knowledge, this study may be one of the first to actually compare decompression within 24 hours to 24 to 48 hours. So further kind of clarifying what is the ideal time to decompression. And we found that patients who were decompressed within 24 hours had a higher incidence of intraoperative hypotension, as I mentioned before, and they also had a trend towards higher rate of post-decompression sepsis, inotrope use, as well as ICU involvement, though these did not achieve statistical significance. This may be explained by possible under-resuscitation in these patients or the fact that they would have gotten a shorter course of antibiotics before getting to surgery. Not quite sure of the underlying cause, but that's a school of thought. So in conclusion, decompression can be safely performed up to 48 hours without compromising patient's outcome or length of hospital stay. Decompression 24 to 48 hours for allowing for antibiotic therapy and fluid resuscitation may improve perioperative morbidity. And the take-home message, I'm not advising urology, my fellow urology colleagues to sit on these patients. That's not what I'm saying. Nor am I giving general surgery the green light to skip us in the emergency theater. But it is important, just as how prompt decompression is important, also important is fluid resuscitation, aggressive fluid resuscitation, antibiotic therapy in these patients. And that's the end of my presentation. Thank you.
Beautiful presentation, Dr. Vaz. Professor Aiken has a question.
Presentation. The baseline characteristics of your three groups, are you sure you accounted for all the possible confounding factors like the presence of things like diabetes, whether they all equally receive antibiotics, etc., the age? Because it would have been nice to have seen a table with the baseline characteristics of the three groups, looking at all the possible factors that might account for the difference in outcome. So how do you respond?
Right. I do have a table, but it's very big and extensive. Yes, the comorbidities were accounted for, diabetes, malignancy, connective tissue disease, the baseline temperature and vital signs, because it's fair to assume that patients who appeared sicker, the surgeons would probably rush with them to the operating theater a little faster, but there was no difference, no statistical difference in that. In terms of antibiotic coverage, I did collect information on antibiotic, but it was a bit difficult. A lot of information was missing. But patients who were decompressed later would have gotten a greater amount of antibiotic doses. Yes, all of that was documented. There was so baseline, white cell count, pulse rate, blood pressure, dipstick, their stone characteristics, all their comorbidities, all of that is documented in the baseline characteristics, and those were examined statistically. They were not found to be.
This one, because I'm not quite sure you should be surprised when patients who decompress less than 24 hours do worse, if so to speak, because you will have examined these patients from a clinical point of view, and you realize that this patient may be more sicker, and if you take this patient more urgently to the operating room. So maybe you can look at one aspect in terms of the clinical presentation of these patients, and as Prof. Aiken mentioned, what are they associating risk factors for these patients, where they're on steroids, where the diabetes, mellitus, where the, and any other contributing factors. Is there a relationship with the size of the stone and the location of the stone that determine the outcome? Because I think the fact is that we all think sicker patients quicker to the hospital, and these patients would likely get a shorter course of preoperative antibiotics. They will become quite unstable and releasing or during the decompression of my inotromes. So that may be a factor as well, why with less than 24 though, and a long ICU stay, although not significant, from multiple studies, but it could be one of the factors.
Yes. Yes, all right. So I did mention those factors, but we didn't notice any difference with those patients based on those factors.
The last time I checked, 30 plus 20 plus 20 is 70.
What was that? So it's 30 plus 20 plus 12, sorry. What, was it 10? Oh, sorry.
Okay, all right. And then the other thing I just wanted to ask you, bearing in mind the comments by our two professors here, you're getting there, don't worry. If you had to design a study to answer the question, which time factor is better, what would you do?
So ideally a randomized control trial, but that would not be ethical. That would be not, that ethical is because the standard of care and the guidelines all say prompt decompression. You're not gonna be justified in sitting on a patient for greater than 48 hours just because of a study. It's an ethical concern, which is why I chose to do a retrospective analysis.
When you do a retrospective analysis, you're telling me that for the most part, the dangers or the expected harm is still relatively low.
Yes. Yes. So I discovered that. I discovered that retrospectively, right? But I'm not sure if we would get that ethical approval to embark on it. We could try. I initially tried to do a randomized control trial, and I was turned down by the ethics board.
Okay, you didn't have the data. No, you have the data.
Okay. Thanks for that, Prof. It's 24 hours from the time of admission to urology. So it would be nice to look at the time from onset of symptoms. That would be the most accurate, I think.
Getting sick and reaching a ward that urologist over you, there are many steps of delay that may apply at any given time. And I think in what you have said about your concerns about whether it would be ethical to do it as a randomized prospective basis, probably is acknowledging that some amount of clinical judgment does come to bear in who gets selected for the 24 or the 48 hours, whatever those parameters are.
Okay, thanks for that.
All right, well done, Dr. Vaz. Thank you so much. Okay. Continue, yes, we like that. All right, Dr. Leo, let us welcome Dr. Leo, Chief Resident in General Surgery. We'll be discussing the risk of recurrent gallstone pancreatitis after deferring same-day admission, cholecystectomy, a real concern or an exaggeration.
The humble general surgeon. All right. Good evening, everyone. So, my name is Matthew, and I'll be presenting my research on behalf of the Section of General Surgery. I have no disclosures. My research is titled The Risk of Recurrent Gallstone Pancreatitis After Deferring Same Admission Cholecystectomy is a Real Concern or Exaggeration, now supervised by my consultant, Dr. Baker. So, acute pancreatitis is common, and the local incidence report is high as 75 per 100,000 presentation, and it's comparable to US figures. Gallstones are the most common cause, accounting for 45 to 70% of all cases, and the vast majority of attacks are mild, about 80%. I know we're not all general surgeons here, so just a quick reminder that gallstones that originate in the gallbladder can cause symptoms here, but sometimes do traverse the common bile duct and incite pancreatitis by several mechanisms. So, the current standard of care for mild gallstone pancreatitis is same admission gallbladder removal due to the reported risk about 18 to 25% risk of a recurrence if surgery is delayed. And accordingly, both our local and international guidelines recommend this. However, prior to surgery, interrogation of the bile duct to see if there are any loose stones that need to be addressed is mandatory. This is typically done either by ERCP or common bile duct exploration at the time of operation. However, the preoperative test that we use as choice, magnetic resonance cholangiopancreatography or MRCP, is not available at our institution, nor is it available publicly at large. So, the scope is that unfortunately there are several barriers to achieving this standard of care. Arranging the transport of the patient, patients affording the study privately, scheduling it, the COVID-19 pandemic, and so albeit ideal is not always achievable. So when MRCP cannot be obtained in our local setting, right, we typically have to discharge the patients to obtain the study and return electively for surgery, which places them at this high risk for recurrence as we had alluded to. However, despite this, we anecdotally noted that incidence of recurrence, we weren't seeing these patients back as high as we predicted. So to evaluate this, we designed a retrospective cohort study for all patients that diagnosed with pancreatitis presented in the University Hospital over this 5-year period. So all patients that were included were over the age of 18 years with an amylase or lipase greater than 3 times upper limit of normal who had a confirmed diagnosis of pancreatitis according to the diagnostic criteria. We excluded patients who had a non-pancreatitis cause of their elevated biochemistry, pregnant patients, as well as those who were less than the age of 18 years. So just a reminder, the diagnosis of pancreatitis requires abdominal pain characteristic with the disease, elevated serum chemistry as outlined before, plus or minus some form of confirmatory imaging, which is not always necessary. You need 2 of the 3. So the aim that we had was to highlight the risk of recurrent gallstone pancreatitis in those patients who did not get their surgery over this 5-year period. We aim to describe the demographics of all patient pancreatitis, those with gallstone etiology, the demographics of those who had recurrence versus those who not. Is there any difference between the two? To highlight the number of cholecystectomies that were done, how good are we achieving the standard of care, and to estimate the risk of recurrence of pancreatitis, right, and this rate of this recurrence. So our results. So I don't know how well it projects, but essentially what we found was our local demographics are keeping with the contemporary literature. The most common cause is gallstones. The majority of cases are mild. Right? Similarly, for those patients with gallstone pancreatitis, a similar distribution is seen, that the mild cases are the most common, right? And there's a female preponderance given that gallstones are more common in women. So when we look at those patients who had recurrence versus those who had no recurrence, we only experienced 5 recurrence. In total, we excluded 6 patients from analysis because their inciting episode of pancreatitis was actually before the study period. We noticed that there was no difference between the 2 groups, whether in terms of gender distribution, severity of pancreatitis, or length of stay. But when you get into the surgery, the standard of care, just to remind you, is for all patients with mild gallstone pancreatitis to receive same admission surgery. Over this 5-year period, only 2 patients at the University Hospital received same admission cholecystectomy for mild gallstone pancreatitis, right? And none of those patients had a recurrence. So when we analyze our data, as I said, only 2 patients received their surgery in the same admission. And the median time to surgery for anybody who got surgery was about 8 weeks from inciting episode. And about 22% of patients never ever received a cholecystectomy. Right? Interestingly, all recurrences occurred within 75 weeks of the index presentation. Right? And this, in terms of predicting the rate of recurrence, worked out about 1 episode of recurrence every 3 weeks. So the endpoint. So the rate of stable admission cholecystectomy at University Hospital is low, about 4.5%. But despite this, the rate of recurrence that we saw is less than the report in contemporary literature, 16% versus 25%, and in some sources it goes as high as 30%. Right? And on average, a recurrent episode occurs every 3.1 weeks without surgery. So how do we use this? So given our well-known local limitations, patients with mild Gallstone pancreatitis may be reasonably discharged to complete outpatient investigation if that can be done within 3 weeks of the episode of pancreatitis. However, we need more local context. The University Hospital represents the most well-equipped staffed tertiary-level medical facility in Ireland, and we need to be cognizant of the more austere circumstances that our colleagues outside practicing, and they may struggle to even adhere to this 3-week compromise. As I mentioned before, all patients who had a recurrence occurred within 75 weeks of the index episode. And even when we follow up the patients up to 200 weeks, the majority never experience a recurrence. So this suggests that there may be a subset of patients who are destined to never recur. And these patients may be reasonably reassured that even longer delays to surgery may not be as dangerous as previously thought. So we are aware that our study has several limitations. It's retrospective, our sample size is small, the proportion of patients presenting with pancreatitis is actually less than we expect based on the population served by the hospital. And additionally, there's limitation identifying all patients with pancreatitis based on their biochemistry. As alluded to, you don't even need an elevated biochemistry for the diagnosis. Furthermore, patients could have recurrence and just did not come back to our hospital. They could have chosen to follow up elsewhere. So larger, multi-institutional prospective studies are required to substantiate our findings, and it's hoped that we will stem such research. So in conclusion, the relatively low rate of recurrence of pancreatitis following deferral of stable admission surgery is a logistical boon on our stretched healthcare system, right? And the proposed 3-week investigative window, which we are much needed, data supported, limitations aside, compromise that balances the safety of our patients with our unique logistical challenges. Thank you.
Thank you so much, Dr. Leo. How many patients did you say did not come back?
No. Did not. Every patient here is all patients who were seen followed up in clinic. Okay. So we were unable to account for those who may have initially presented and then chose to follow up for their recurrence elsewhere.
So you were able to verify that those who did not come back did not go elsewhere for their treatment?
Correct. This was done using our clinic system. So patients who are discharged and subsequently returned.
You actually presented a write-up, and because very excellent study. Right, because I think it's important to know what you want to know. But where I got confused was reading your document. You have some aims, you have a lot of objectives, and then you presented some hypotheses. And then you subsequently presented your work, right? So I would encourage you to read over your document to make it matches everything that you wanted to say. I can't remember everything offhand, but it does not match. For example, your hypothesis, I'm not sure if you know, you prove them or disprove them. Now, with the results, I wasn't sure what Table 1 and Table 2 was telling me. Table 1, you're really looking at outcomes for those readmission or recurrence for those who have gallstone dependent pancreatitis, right? So your Table 1 looks at the features of people, everybody with pancreatitis, which we can kind of take out. There's 76 people, 55 of those were due to gallstones. So good, but then we come on to Table 2. Then I see cholecystectomy performed in 34 of them. That's the row down at the bottom. So I'm not sure what stage this table is presenting. It's obviously not baseline.
What do you mean by baseline?
I mean, when did these guys have cholecystectomy? Because we're talking about...
It was mixed. So some patients came, got surgery, well, 2 patients came, got surgery, same admission.
Present results. We really want to know what those results are saying, right? Is it baseline characteristics? Is it characteristics over a period of time, which has to make sense because I am now confused. Are you saying 34 of the 55 had cholecystectomy at some time, even though you're looking at whether these cholecystectomies are same admission or not? Trust me, I read your document a couple of times. It took me about an hour because I was trying to figure out, and then you did this. And then you have cholecystectomy for no recurrence and recurrence. So tell me, 55 people index cases of gallstone pancreatitis, right? How many of them had same admission surgery?
2.
2. So you're looking at the other 53.
Well, we're looking at the entire population and saying that despite us not really meeting, well, that's one way of saying it, the vast majority of patients who did not meet this criteria, whether or not they got their cholecystectomy within 6 weeks, 6 years, 2 years, that they're not recurring as frequently as we would imagine. The push to do the surgery in that same admission may not be validated. That's basically what we're saying.
I understand all of that. I got all of that, and that's why I said at the outset that I think it's an important study from the patient's perspective, or what a surgeon or a GP can say to their patient in front of them. But I am not understanding your results at all because they are very, very confusing. Disclaimer, you presented some very fancy statistics. It's beyond me. Prof. Reed, if you read the paper, can probably make sense of it.
No,
but I can't, but I can make sense of your results. I think the results, the presentation of results really needs to be redone because based on what your objectives are and what you really want to do in your paper and what your hypotheses are, they're not clearly presented here. So you're saying 53 people did not have surgery, same admission surgery, and you want to see what their outcomes are like. And then you go on to say you went on and followed up many of them for up to 200 weeks, which is almost 4 years, but yet you say that waiting for surgery for 3 weeks might be a good time because that 3 weeks is coming from your statistical work.
The 3 weeks is not for surgery, you know. What we're saying is that based on the incidence of recurrence that we're seeing, one recurrence presents at the hospital every 3 weeks. So if a patient needs to leave the hospital to be investigated, you would not expect that for that patient to recur if they came back and had their surgery within that 3-week period. That's what we're saying.
I wasn't sure what you meant when you said that one patient is presenting every 3 weeks.
So the
recurrence.
Right, so the average, so when you work out all the recurrences that we saw over the time period, we saw one every 3 weeks, basically from index presentation to when they came back. That's how it was distributed.
You only have 5 recurrences?
Yeah.
The limitations are the small sample size here. Let me just... So, all of them occurred within 75 weeks of presentation, sir. Within 75 weeks. And on average, it worked out to about one every 3 weeks, right? Within that time frame. So it's difficult to say who will present when, but just based on the law of averages, patients have to go home anyways. There's no reason to keep the patient in hospital to wait for the investigation. And if I'm going to give him a reasonable time frame, because everybody wants a time to work with, Doc, how soon should I do this? Given the limitations, because these kind of information will never be substantiated where these guidelines are written because those patients achieve the standard of care. So given the best opportunity to advise someone who has no other choice, I thought, this was reasonable to say.
So typically when you're doing a Kaplan-Meier analysis or time to event analysis, there are a couple of things that you have to be clear on. So this is really following the group of individuals who had pancreatitis within the 55 individuals that you have. And then therefore the event that is going to occur is a recurrence, all right? So the question for me is, when were they censored? Were they censored at recurrence, right? When they had the recurrent pancreatitis? and the recurrence, the other censoring would occur at what time point?
They were censored when they had the recurrence. Each one that.
People who had events. For the people who did not have events, when were they censored?
So I don't think we had captured that in this presentation. Yes. No, so ask the question again, because I understand the first part.
For the time to event analysis, you went to censor the people at the point at which they have the event. So we see 5 people would have had things, so that whatever that date is, or that period is. Then for those who did not have the event, what time did you censor them? What was the last point in which you saw them? Was it 4 years, 5 years?
Oh, I just understand what you're saying, sir. So, so each patient that did not have the event was seen at least up to 6 weeks in clinic post-op, but each patient, the entire population was followed up to 200 weeks.
And so typically when you're presenting this, you would put the time period at risk, so you know what the time is at risk is, and then you'd express the number of events per that denominator in terms of the number of the time at risk. That's also the typical presentation would go. All right? But that's fine.
All that has been said, I want to congratulate you on what I think is an excellent study, because it is particularly relevant to our setting, and it potentially allows us to have guidelines specifically for our setting. As you said, a study like this won't be done in a resource-rich environment. So I want to congratulate you.
I don't understand.
Thank you very much, Dr. Leo. I'm going to invite Dr. Renette Alexander from Pediatric Surgery to present her paper.
Good afternoon, Madam Chairperson and colleagues. My name is Renette Alexander, and today, on behalf of the Pediatric Surgical Department, I'd like to present an update on the non-operative management of intussusception at 2 major hospitals in Kingston, Jamaica. Intussusception describes the telescoping of a proximal segment of bowel into the distal segment, and it is the leading cause of obstruction in patients aged 3 months to 3 years. Untreated, the natural order of things would be venous congestion, lymphatic congestion, finally leading to arterial occlusion, leading to perforation. The management of this condition has evolved since it was first described in the late 1800s. Traditionally treated with operative management and manual reduction, the standard of care now for uncomplicated cases would include non-operative management under radiologically guided enema reduction. There are several ways and several modalities that can be used. Firstly, pneumatic reduction under fluoroscopic guidance, which is the modality of choice at the University Hospital of the West Indies. The air deflating pressure should not exceed more than 120 millimeters of mercury. Hydrostatic saline reduction, depicted here, is the method of choice at the Bustamante Hospital for Children under ultrasound guidance. And here this just demonstrates the intussusception or the ileocecal region being reduced as saline is instilled with free flow of saline into the terminal ileum, which would represent a successful case of reduction. Other methods also exist, including hydrostatic barium reduction and pneumatic reduction under ultrasound guidance. Whatever the modality of choice chosen, it is generally accepted by organizations such as the American Pediatric Surgical Association that a successful reduction rate of an institution should ideally be more than 70%. The experience with the non-operative management of intussusception in the region has been documented, firstly by Duncan et al. In 1998, who prospectively documented their experience with hydrostatic reduction of intussusception with a success rate of 54%. There were 2 perforations and 1 mortality in that study. Subsequently, at the University Hospital, pneumatic reduction under fluoroscopic guidance became the modality of choice, and Johnson et al. In 2008 documented a success rate of 56%. They identified factors such as patients being under-resuscitated and inappropriate staffing, the lack of staff accompanying patients to the department, which they thought contributed to the lower than accepted reduction rate in their series. Finally, out of Trinidad and Tobago from the Eric Williams Medical Sciences Complex, Pran et al. Documented an increase in success rate of barium reduction from 41% to 66% over an 8-year period via 2 audits. And this was following the introduction of delayed repeat attempts at non-operative management when cases were unsuccessful but remained hemodynamically stable. So, with a view to continually audit ourselves and improve our outcomes, we conducted a multi-center retrospective observational study reviewing the records of children diagnosed with intussusception at the University Hospital of the West Indies, as well as the Bustamante Hospital for Children, between January 2016 and December 2020. The records were reviewed and the data was analyzed using the statistical package for social sciences. Our primary outcome was the success rate of non-operative management of intussusception at these 2 institutions. Secondary outcomes that we conducted and we looked at were the factors affecting the success rate and the overall length of stay. We included all cases of pediatric intussusception which were confirmed by ultrasound and excluded cases that were diagnosed incidentally at surgery. Our total number of cases was 64 cases. The mean age of presentation was 15 months, and the male to female ratio was 2:1, in keeping with the recorded data of a male predilection. The age and gender did not statistically correlate to an increased or decreased success rate. In the majority of cases, the intussusception was an ileocholic intussusception. However, it should be noted that in 35% of cases, the type of intussusception was not documented. And this precluded us from analyzing how the type of intussusception affected the overall success rate. 66% of the cases were considered appropriate for non-operative management and selected to do so. And in the vast majority of cases, pneumatic reduction under fluoroscopic guidance was the method of choice. Unfortunately, due to decreased numbers in the hydrostatic group, we were unable as well to see if the modality of choice impacted our overall outcomes. A total of 64 patients were identified, and attempted non-operative management was performed in 40 cases, with an overall success rate of 60%. This represents an increase in success rate of 7% compared to the previous series by Johnson et al. In 2008. However, with a p-value of 0.835, it was not determined to be statistically significant. However, when we look at the success rate by year, we noted a general trend towards an increasing success rate from 40% in 2016 to 100% in 2020. During this study period, the Bustamante Children's Hospital underwent a change in the predetermined modality used, where they converted from pneumatic reduction to hydrostatic reduction under ultrasound guidance. We were again unable to say if this impacted our outcome statistically. There were several clinical parameters that we looked at to determine if these would or could predict the ability to, 1, successfully reduce an intussusception non-operatively, and 2, the effect overall on the duration of stay. We looked at age, gender, symptomatology, as well as hematological and electrolyte disturbances. However, it should be noted that there were many cases of missing data, and that decreased the overall numbers which we were able to assess this with, and we were unable to determine a statistically significant impact from these clinical parameters on the overall outcome. There were other outcome measures that we looked at during this period. Apart from the success rate, which was quoted at 60%, the duration of stay was noted to be significantly shorter in patients who were managed non-operatively at 2 days, with a mean of 2 days, compared to a mean of 11 days for patients who were managed surgically. And considering that duration of stay is often used as a surrogate marker for institutional cost, one can extrapolate how decreasing the duration of stay can lead to overall decreased institutional cost. There were no major procedural complications in the non-operative management group. There were 2 perforations in the non-operative management group, noted at laparotomy following failed procedures, and this represented a perforation rate of 5%. it is generally accepted by organizations such as the British Pediatric Surgical Society that an acceptable perforation rate is less than 3%. It should be noted, however, that these perforations were not clinically detected at the time of the procedure. They were noted at laparotomy. So we're actually unable to say whether these occurred as a result of the intervention or as a result of continued bowel necrosis and eventual perforation. The recurrence rate after successful non-operative management was 4%. This, regardless of the method of non-operative management used, data from international studies and better resource centers quote a recurrence rate of approximately 10%. So we are within range with that. And the mortality rate was 0. We did have some limitations. Apart from this being a retrospective study, the sample size was small, and there was poor documentation, which led to missing results. Missing results at times sometimes decreased our sample size by as much as 19%, and we found that this limited our ability to correlate certain clinical factors to our outcome. So, in conclusion, the success rate of non-operative management of intussusception in Kingston, Jamaica is 60%. And at 7% increase from the previous reports, this does not represent a statistically significant increase. The length of stay, however, is statistically significantly decreased with non-operative management with a p-value of 0.001%, and the assessment of clinical factors which influence success is limited by small sample size and poor documentation. This is the first documented follow-up on intussusception at the university hospital since 2008, and the first documented experience on the management of intussusception at the Bustamante Hospital for Children. So our recommendations and our future perspectives are we would like to conduct an extended period of study with the aim of increasing the sample size, prospective data collection with particular attention to documentation, scheduled audits every 5 years, and a written institutional protocol, which we hope will inform the selection criteria for non-operative management, what constitutes a single attempt at non-operative management, and then a protocol for delayed repeat enemas with the hopes of improving our success rates, and the presence of the pediatric surgical staff during the procedure for all non-operatively managed cases, as well as developing discharge criteria for these patients. These are my references. Thank you.
I think Professor Reed has a question now.
Were there any differences between the non-operative management group and the operative management group in terms of success? Was there a difference between them?
So patients that were managed operatively, because it constitutes us physically undoing the intussusception, they would be 100%
success.
Yeah.
All right, that's clear. The other question I wanted to do is to look at some of the things that you say that you wanted to do based on the small size. And you mentioned the scheduled audit every 5 years. What do you mean by that?
Okay, so as I mentioned, the experienced bodies quote that a success rate of more than 70% is what is considered acceptable. And if an institution is unable to have a success rate of greater than 50%, it is actually advised that that institution should cease the procedure, have retraining of the staff, and then attempt to do this again. Scheduled audits is suggested by groups such as the British Society of Pediatric Radiologists to...
Walk me into the steps of the audit. What would the audit, broadly speaking, look like?
Understood. Broadly speaking, it means every 5 years, we look at all the cases that were managed non-operatively and see how successful we are. There should be a trend towards either increasing or maintaining success rates. And if this is not the case or we don't meet standards, we should also look at what were the causative factors in this, which is what we hope to do in this study, but we had certain limitations.
And then what is to do after that?
Right. Identify the limitations and then make improvements before the next audit. When Johnson et al. Did their study, they identified limitations such as staff not being present and the patients were dehydrated. Now, it is generally understood that a pediatric surgical resident attends all cases of non-operatively attempted reduction. The patients are not taken to the department unless they are fully resuscitated and have documented measures to state that they are rehydrated. when I was conducting this study, what I noted, despite knowing that that is a standard here, it's often not documented. So we aren't able to see how those interventions affect the outcomes. The hope is that going forward, we can document that those changes have positively impacted the outcomes, and hopefully once we have our written protocol, this will help us to achieve international level success rates, which we are currently not at.
So in essence then, what you're suggesting, I think I'm hearing you, you're trying to get there, is that you would make a baseline assessment of what is your outcome in terms of non-operative things.
Yes.
All right? And then once you've made that assessment, you would then examine what are the aspects of your protocol, right? So you'd have to compare that against a protocol of some sort.
Yes.
You then examine it to see what aspects of your protocol is contributing to that. And then you would revise the protocol or put into place some form of process to ensure that there's greater compliance with the protocol?
The revision of the protocol would be dependent on the outcome, and the only way to highlight that the protocol was adhered to would be to look through the notes and see it documented.
Look at that. Yeah. So remember now, audit, the point I'm trying to get to is an audit is a cycle and is a health service improvement mechanism to ensure that you get better quality outcome.
Right.
So essentially what you would do is that you would have to identify when the protocol is not being followed, revise that, train the staff on this revised protocol, all right? And then at the end of the 5 years, you make the assessment again to see if there's an improvement. So it's always a cycle.
Understood. That is the hope.
Well, I know it. You need to tell me. All right, go on.
Thank you.
One quick comment. Dr. Alexander, very nice presentation, very nice abstract, was very well done, and you presented it very nicely. And I guess, and I can't remember Intussusception since medical student days, which was very long ago. But I guess there are factors that determine when you go straight to operative and when you don't. So that's fine. But looking at the slide before this, I think the conclusion slide, you said that the one thing that was significantly different was length of stay. Yes. And here you're comparing what? Length of stay for non-operative management versus failed non-operative management?
Length of stay for successfully managed, patients who were successfully managed non-operatively, and those who had surgical intervention. So patients who had surgery or who didn't have surgery.
So you're not comparing the failed?
No, not
because the failed would obviously have longer length of stay.
Right.
Okay. All right. So that was the 2 versus 11.
Right. So patients who didn't have surgery stayed on average 2 days, and those who had surgery stayed on average 10 days. So we hope that if we could promote a culture where you make the patient eligible to non-operative management, you can have overall decreased length of stay, decreased institutional costs, and so forth.
That's the only thing.
And benefit to the patient.
That's good.
Thanks.
Well done, Doc. Thank you. Dr. Matthews. Let's welcome Dr. Matthews from General Surgery.
Good afternoon, everyone. I am Rico Matthews, a Chief Resident in General Surgery, and I'll be presenting my research paper titled Colonic Evaluation in Patient Presenting with Inguinal Hernia Should Be Mandatory. My supervisor is Dr. Akil Baker. I have no disclosures. So a bit of background. Globally, colorectal cancer stands as the second most prevalent cause of cancer-related mortality in both men and women. Within Jamaica, it ranks third in cancer-related mortality in females and males. When diagnosed early, the survival rate is greater than 90%. and screening has shown to reduce both the incidence of colorectal cancer and mortality from colorectal cancer. Over the last 5 decades, colorectal cancer has been hypothesized as a risk factor for inguinal hernia, and there have been older studies which have demonstrated high association of colorectal cancer at about 70 to 22%, and inguinal hernia, and patients who had colon cancer having an inguinal hernia within 2 years of treatment, whether before or after treatment. Despite these earlier studies showing this increased association, there have been contemporary studies that have shown low likelihood of colorectal lesion in patients with inguinal hernias who are asymptomatic of colorectal cancer. And in our population, Couch et al. Noted that approximately 20% pickup rate of colorectal polyps in patients who undergo opportunity screening performed at University Hospital. However, there have been no data locally or regionally looking at colorectal polyp, whether adenoma or cancer, and in patients who had inguinal hernias who were otherwise asymptomatic for colorectal cancer. Currently, opportunity screening in patients 50 years and older with inguinal hernia is common practice at the University Hospital. And this practice is not supported by literature out of the North America and Europe, demonstrating a low rate in detection in these patients who are average risk. Preoperative opportunity screening delays surgical management of inguinal hernia due to a significant wait time for colonoscopy within the public sector. And some patients may even develop complication of their disease, whether that be incarceration, obstruction, and strangulation, and requiring emergency operation during that wait period. So our aim was to evaluate the association between inguinal hernias and the presence of colonic adenoma or adenocarcinoma upon opportunity screening. We have a couple of objectives. We wanted to calculate the adenoma detection rate for a patient with inguinal hernia who had an opportunity screening colonoscopy. And that is calculated by the number of colonoscopy with adenomas or carcinoma divided by the total number of colonoscopies and multiply that by 100. We also wanted to compare the adenoma detection rate between patients who had an inguinal hernia and those without inguinal hernia. We set to describe the demographics of patients with inguinal hernia who had an opportunity screening colonoscopy, and also demographic factors which may increase the adenoma detection rate in patients with inguinal hernia who had an opportunity screening. We also set to look at the interval of first encounter in the surgical outpatient department and the time to hernia repair, and also the wait period for opportunity screening colonoscopy in patients with inguinal hernias. How we went about doing this? It was a retrospective docket review of patients who had screening colonoscopy done at University Hospital between June 2018 and December 2022. The study participants were identified using the UHWI minor operating theater logbook, as that's where colonoscopies are performed, and also the hospital information management system to identify all patients who had screening colonoscopy with or without inguinal hernias. We identified demographic features, age and sex, hernia location, date of colonoscopy, the findings of these colonoscopy, the histological findings, date of presentation to the surgical outpatient department, date of their hernia repair, and last day of follow-up if they were not operated on. We included all patients over 18 years who had a screening colonoscopy. We excluded patients who had symptoms suggestive of colorectal cancer or who had more than average risk for colorectal cancer. Those patients, IBD, personal history of colorectal cancer, or family history of colon cancer-related syndromes. Our continuous variable were described using median and interquartile range, and we compared with Wilcox and rank sum tests. These are non-parametric tests, and we use it because we're uncertain of the distribution of the variables that are assessed. Our category variables were described with numbers and compared with Pearson or Fisher exact tests. And the time to event outcomes were described with Kaplan-Meier curve and compared with log rank tests. Our statistical significance was taken to be less than 0.05, a p-value less than 0.05. The sample size, because the study was an exploratory study, a strict sample size was not needed. However, using contemporary literature showing that ADR is about 25% plus or minus 1, we assuming a change of 10% to be significant, we use that to calculate the sample size and to have a significant level of a p-value of less than 0.05 and a power of 0.9. So the results, the demographics of the patient who had colonoscopy, well, we identified 1,766 colonoscopy that were done during the time period. Of those, 323 patients had a screening colonoscopy. The median age was about 62 years, and male and female were a similar distribution. For patients who had a screening colonoscopy, about 51% of them had no hernia, and 41% had an inguinal hernia. And the adenoma carcinoma detection rate was about 20%. When we stratified the patient based on inguinal hernia and no inguinal hernia, we found that patients with inguinal hernia were on average 4 years older, about 64 compared to 60, and that was significant. We also identified that 89% of the patients with inguinal hernia were male, as inguinal hernia is more common in male than female. The adenoma carcinoma, or the adenoma detection rate, was 21% in patients who had an inguinal hernia, and also 21% in patients who did not have an inguinal hernia, and clearly there was no difference. Of the 27 patients who had an inguinal hernia and a statistical significant histology, only 3 patients had a diagnosis of adenocarcinoma. And these 3 patients had their surgical plan altered, and these patients all got segmental colectomy along with simultaneous hernia repair. Therefore, the findings from the preoperative colonoscopy only altered about 2.3% of patients with inguinal hernias. And this gives an estimate of number of colonoscopy need to detect a surgical altering malignancy at about 43. The median time for preoperative screening colonoscopy for patients with inguinal hernia was about 138 days. And the median time to hernia repair was 346 days, nearly a year. 19 patients in the study population had an inguinal hernia repaired prior to their colonoscopy. And we used those 19 patients to calculate the possible wait time for hernia repair if colonoscopy was not done. The median wait time for this group for hernia repair was 133 days. Therefore, the wait time for hernia repair was lengthened significantly, both statistically and nominally. This is a Kaplan-Meier curve looking at the wait time for surgery, and the 2 groups are patients who had a colonoscopy, preoperative colonoscopy, as seen by the red line here. And this green line is an estimate of what it would have been if we had foregone the preoperative colonoscopy. So amongst patients who are screening colonoscopy, patients with inguinal hernia are more likely to be older and male gender than compared to patients without an inguinal hernia. The study revealed that no significant difference in ADR in patients with inguinal hernia versus those without. The percentage of patient management that was altered due to a preoperative colonoscopic findings was extremely low, and the wait time for hernia repair was lengthened due to waiting time for screening colonoscopy. What are the limitations of our study? Due to its retrospective nature, the study scope was confined to the available data, so therefore we may have missing colonoscopy report. However, we made attempts to get this information using other supplementary sources, such as the HIMSS system. Incomplete referral dates for screening colonoscopy among certain patients hindered the ability to compare the waiting time for patients who did not have inguinal hernias. The study confined to a single center implies that the findings may not be easily generalized to other institutions. And finally, the study did not consider certain patient-related factors that might have lengthened the time to surgery or even colonoscopy, such as comorbidities and all of that. Our recommendation is that patients with an inguinal hernia older than 50 years old with no colonic symptom and has average risk for colorectal cancer their surgery should not be delayed by waiting on a colonoscopy. However, patients who present with colonic symptoms, on the other hand, should undergo a diagnostic colonoscopy. So in concluding, there is no association between inguinal hernia and the presence of colonic adenoma or adenocarcinoma, and this is in keeping with contemporary studies. And mandatory preoperative screening colonoscopy is not justified in our population based on our findings. These are references.
Thank you very much, Dr. Matthews. I think the judges have some questions.
Your objective slide again. No, but for the forward. All right. Okay. All right. Okay. All right. You're good.
I think this is a very important paper because patients have died because of this nonsense about mandatory colonoscopy and that renal hernia. And it probably would be worthwhile if we know that colonic cancer can kill you, but inguinal hernia kill you also, and that should have come out. And I know of patients who have been sent for colonoscopy, who presented with inguinal hernia, and died because they got obstructed while they're waiting on the colonoscopy, and it was forgotten. They didn't get it. So the subset of patients who are going for colonoscopy, we need to assess if they've got a hernia, the stage of the hernia, and if it is certainly hernia, that needs to be done. The colonoscopy brought about after. So I guess your conclusions are worthwhile.
I want to congratulate you on a very good paper. I think it's like Dr. Leo's paper, a practice-changing paper that's relevant for our institution. And I want to congratulate you on that. You've made a statement, though, that I want you to explain for me. Very early in your presentation, you said that screening reduces the incidence of colorectal cancer. Explain.
Good. So screening colonoscopy identify pre-malignant lesion. So identify adenomas, tubular adenomas, villous adenomas, and remove same. These that may have developed colon cancer in the future. Usually take about 10 years for colon cancer to develop from an adenoma to a carcinoma. So in screening and removing these pre-malignant lesions, there's a decrease in the risk of colon cancer.
Okay. It's getting exciting in here, isn't it, right? Let's welcome Dr. Hope. Let's hope he maintains the momentum. He's going to present on the application of a novel scoring system to predict mortality in elderly patients sustaining low-velocity hip fractures, managed surgically at a tertiary teaching hospital.
Good afternoon, everyone. Thank you for the opportunity to present. Dr. Hope presenting on the behalf of the orthopedic organization here. This title is a mouthful, so my study is the application of a novel scoring system to predict mortality seen in elderly patients sustaining low-velocity hip fractures managed at a tertiary teaching hospital. This is our outline. So jumping straight in, we identify a problem in managing patients, and that's the epidemic of hip fractures, where the global incidence is reported to be as high as 100 cases per 100,000, with a prevalence anticipated to be 6.2 million in the year 2050. And in addition to that, there's a significant financial burden that we see because of management of patients with hip fractures. In the United States, the cost reported is $5.9 billion, which is 72% of their fracture-related costs, even though hip fractures account for only 17% of their case presentations. And we have local data as well, published here at this institution in the year 2014, where the cost documented was $46 million per year at that time. And this was a study done by Vaughan et al. So in our study, it was a retrospective cohort study done between January 2016 to December 2019, and it was located here at this institution, and we captured 148 cases managed then, and we, of course, obtained the relevant ethical approval. Our inclusion criteria was first, all patients 60 years or older managed here at this hospital who sustained a low-velocity fall, which we define as a fall from a bed or standing height, and had a confirmed hip fracture on radiology as identified by the different subtypes, and they were managed surgically at our institution using different techniques. Our exclusion criteria implicitly was therefore all patients less than 60 who had a high velocity mechanism. We opted to exclude those who were managed privately because we thought that might introduce some bias and confounding. And of course, hip fractures that we thought were secondary to either suspected or confirmed pathology, we excluded those as well. So we extracted the data from our patients' medical records, whether they're dockets or electronic medical system. We then converted this information into a data sheet, which was then converted to electronic format for statistical analysis. Shown here is that data sheet showing the different parameters that were collected. And we then obtained our mortality information predominantly from the Registrar General's office, and we supplemented that with telephone calls and the birth and death department here as required. Just to mention the novel scoring system, shown here is very simple, and it's information that can all be captured on presentation from the patients. And the categories we evaluated were age, comorbidities, their premorbid activity level, and their mentation at presentation. Our aim, therefore, was to see if this novel scoring system correlated well with mortality, and to see as well if it also correlated with post-operative complications. We did univariate analyses, as shown here, mean, standard deviations, etc., for simple data, and bivariate analyses to evaluate for any correlations, especially with mortality and perioperative complications. And we also did a logistic regression model to evaluate the significant association with mortality. So our results. First, looking at our demographic information, we saw that our patients, their gender was predominantly female, where 73% of our patient population, 108 were female, compared to 27 being male. And the age of our patients ranged between, as we said, more than 60 to as high as 104, with our patients predominantly being in the 80 to 89 subgroup, which accounted for near 50% of our patient population. Looking at the parameters that we collected perioperatively, we looked at certain blood investigations, namely hemoglobin, blood urea, nitrogen, and creatinine levels, of which majority of patients had normal parameters. 76 had normal hemoglobin and BUN on presentation, and just about 80% had normal creatinine as well. Looking at our intraoperative parameters, we'd highlight two, which was the time to surgery and the length of stay in hospital, where the time to surgery varied widely between 1 day to 73 days, and the length of stay varied between 2 to 50 days. And this is represented here on this box and whisker plot. As said before, the average time to surgery was 9 days, and the average time length of stay was 14 days. Looking at our perioperative, post-operative complications, we saw that 49 patients had post-operative complications, and we also see the outcome we looked at was mortality at 30 days and at 1 year, where 1 patient sustained mortality, and at 30 days and 22 patients at 1 year. So the distribution of complications we took note of, anemia was the most common complication, accounting for 26% of complications seen, and this was followed by UTI, 15%, decubitus ulcers, 11%. Of note, the comparative distribution of these postoperative complications in those who had mortality versus who did not, UTI and decubitus ulcers were the most common postoperative complications seen in those who sustained mortality. Quickly going on to our statistical analysis and our novel scoring system, we found that some of our perioperative parameters had near statistical significance, BUN being one of them, where the p-value was 0.54. And we also took note that blood loss had also near statistical significance with a p-value of 0.51, and that is blood loss greater than 400 mils was found to be significant. Interestingly, our novel scoring system, as shown here, the average score in those who were alive was 8, whereas the average score for those who sustained mortality was 10, and this was found to be statistically significant with a p-value of 0.09. Why is this important? When we did our logistical regression model, we found that the odds ratio was reported to be 1.37. What this communicates is that a 1-point increase in that novel score correlates with a 37% increase of mortality. To report our mortality statistics, we found that our 30-day mortality was quite low compared to international literature, which we will mention in the discussion, which was less than 1%, where we had 1 episode of mortality in our 126 patients, whereas the 1-year mortality was 23.1%, with 22 patients unfortunately demising. So looking at our discussion, first looking at the international literature, we found that in multiple studies, 10 specifically that evaluated mortality seen in elderly hip fractures, the mortality rate at 1 year ranged between 12.7 to 39%. And in one particular study done by Snell et al. With a patient population of 758, their mortality rate reported at 1 year was 21.2%. However, this study was significant because it identified certain factors that were predictive of mortality, and these included age, male gender, low Parkinson's mobility score, and a Charlson score of greater than 4. Dawes, in their study, they found the application of a score, namely the Cernborn score, was found to be beneficial and correlate with mortality, specifically with 30-day mortality, and the score is shown to the right, looking at different parameters. So this formed the basis for our own novel score. But however, in evaluation of the different scoring systems that have been used in the medical literature, none have been found to accurately correlate with mortality. And Kirkland, in their study, and Burgos confirmed this as well. Looking at our own literature information compared to international literature, our average age was 82, which is consistent with the literature. In this table, it shows different studies that were done showing the age distribution of patients ranging from 78 to up to 84%. Even Vaughan, in his study in 2014, their average age was 84. Snell, in their study, as mentioned before, mentioned these factors, and we see here shown the odds ratio that was done in that study as well. And this study shows the different studies that have been done to evaluate perioperative mortality, 1-year mortality, and it shows that it varies widely, as we said before, ranging between as low as 4% to as high as 39%. Interestingly, some studies show a preponderance with females versus males. Looking at our novel score and our research, we found that novel scoring system was found to accurately correlate with mortality, and we identified the p-value there already, and we noted the significance of predicting increased mortality with a 1-point increase in the novel score. We also had some near correlates with mortality, elevated BUN, and blood loss, and this may give credence to making this novel score a bit more robust and evaluating it. So in summary, our recommendations, we think a national prospective study would be beneficial to further demonstrate the correlation with mortality and hopefully lobby for resources to improve our ability to offer surgery in a timely fashion. And we think a prospective arm with an interventional component may be beneficial to see how we can risk stratify our patients and offer them surgery in a timely fashion and hopefully modify their mortality. Limitations, there was some bias, missing data, and we had significant missing data with as well obtaining our mortality results. And I thank you for your time, and these are my references.
As a question?
Wally. All right, Doc. Perhaps the most pressing one that I have is the explanation that you have for your odds ratio. You mind repeating that for me again?
Let me preface it under the advice of my statistician. She No, sure. So what she said is that the odds ratio of 1.37, that interpretation was that for each 1 point increase in the novel score, the increased percentage of mortality expected was 37%.
That's wrong.
Okay. Well, I stand corrected. Thank you, sir.
So it's an increase of 37% in the odds, not in the percent.
Sure.
All right?
Thank you.
Big difference. All right? So now that you've gotten that part right, the other question I just wanted to ask you, you keep using, and you're not the only one, you keep using the word correlate, when in truth and in fact what you actually mean is associate.
Okay.
Correlate is a specific form of association, in which the expectation is when you demonstrate to me or tell me a correlation coefficient.
Okay.
But you're not, right? You're checking for some association. That's language issues. And then my final thing is that I support the logistic regression in trying to show an association between some predictor and an outcome. However, you had a novel score that had a range from 4 to 28. So you had 4 groups. Maximum score you could have gotten was 28. Minimum score you could have gotten was 4.
Well, maximum score would be 60.
60? No, you said 4 to 1. You can find out that slide quickly. Because I'm sure, if I remember correctly, I had 4 categories or 4 domains, and the maximum that you gave in any domain was 4. Then you had 2, and then you had 1.
Yes, that's correct.
Right. And if you have 4 domains with a maximum score of 4, last time I checked, 16. So it would be 16 would be your maximum score. Because you could only get 1 score from each of those specific domains, right? Yes. All right. So in each of those domains, the maximum score you could get was 4.
Yeah.
Right. So 4 by 4 is 16.
Yeah.
All right. Now, the issue for me is, why didn't you then tell me what was the cut point that was associated with the greatest sensitivity of you classifying somebody as being dead versus not dead?
I agree that that would be quite instructive, but I think because of the relatively small sample size.
No, that's not the reason. The reason is because you didn't use the analysis. So the analysis, again, you have a continuous outcome, a continuous variable, in which you want to say what point in that continuum is predictive of an outcome, which in this case is death versus not death. The approach, again, is the receiver operating analysis so that you can identify the cut point that maximizes your sensitivity and your specificity. All right, that sum of your sensitivity and specificity gives you what is the ideal cut point for that score.
Okay.
All right? And then, so that what that basically meant was that you then showed me a slide which was basically redundant, because you then said, in this case, your outcome is death. Death versus not death. But then you showed me another slide in which you're using your NSS as an outcome. But your hypothesis is that it's death is the outcome.
Okay.
All right, so that wasn't necessary. All right, that's it.
I just had, I think the 62 was, this is the 10th presentation, so numbers are messing up with my head.
That's
So
right.
62 people you were studying?
No, 140.
148.
I'm confused.
148.
So yeah, the numbers might not be too bad for a rock curve analysis. I was thinking 62, and that would be small. But you do have a lot of missing data.
Yeah.
You did identify that as a limitation. Did you account for that in any way when your analysis were done, and what could that
Yes, specifically for the mortality data, we decided instead of using the total patient population of 148, we limited the N to the number of patients we were able to confirm the end result, whether dead or alive. So at 30 days, the N would have been 123, which we could have confirmed, and at 1 year, it was 95 that we could confirm. And we thought that would make the mortality statistics more accurate.
A little bit more dependable, yeah, that's great. And yes, I agree with Prof. Reed that it'll be nice to attempt some kind of cutoff, or suggest some kind of a cutoff. So this novel scoring system, it exists, or this is your own scoring system that you have put together?
So the closest scoring system is the Cernborg score that I mentioned previously. How they constructed their score is a bit different, but in principle, we use some similar parameters based on Snell's study. This is our own score. Yeah, never before used.
What is this? The Hope scoring system?
Until published.
Good stuff. Thank you.
Good work. All right. So we're going to close off this evening with none other than Dr. Gaynell Menzies, our Chief Resident in Urology. She'll be presenting on the prevalence of 5-alpha reductase inhibitor adverse events in patients with BPH.
Good evening, everyone. I'm Dr. Gaynell Menzies. Thank you all for staying until the end. I'd like to present my research paper titled The Prevalence of 5-alpha reductase inhibitor Adverse Events in Patients with BPH in Jamaica. Benign prostatic hyperplasia and its symptomatology affects the aging male. Dihydrotestosterone influences both normal prostate development and the progression of BPH. The conversion of testosterone to DHT is carried out by the enzyme 5-alpha reductase. 5-alpha reductase inhibitors incite prostatic epithelial involution, slowing the progression of BPH by lowering serum and intraprostatic DHT concentrations. 2 5-alpha reductase inhibitors exist presently, finasteride and dutasteride. The use of 5-alpha reductase has been associated with several sexual and neuropsychiatric adverse effects. The most prevalent side effect is erectile dysfunction, followed by ejaculatory dysfunction, loss of libido, and decreased ejaculatory volume. Psychiatric adverse effects include depression, suicidal ideation, and anxiety. There's also an increased risk of gynecomastia. The constellation of all these adverse effects of 5-alpha reductase inhibitors is termed post-finasteride syndrome and has now been included in the National Institute of Health's Genetic and Rare Diseases Information Center. Currently, no studies exist establishing the prevalence of these adverse events in Jamaican men being treated with 5 ARIs for their BPH. Developing knowledge of this will aid in optimal patient counseling prior to commencement of these medications by local urologists, as well as facilitate screening for these adverse effects and managing accordingly to improve the quality of life in this patient population.
The objective of this study was to determine the prevalence of adverse effects of 5 ARIs in patients with BPH in Jamaica. These include sexual dysfunction, depression, and gynecomastia. This was a prospective cohort study that was conducted in the outpatient departments at the University Hospital of the West Indies and the Kingston Public Hospital between September 2021 and September 2022. Ethical approval was granted from the Ethics Committee for the respective institutions. The study population comprised of patients with BPH treated with 5 ARIs, all patients with a diagnosis of symptomatic BPH being commenced on 5 ARIs were identified by urologists and directed to a research assistant who was independent of the medical team. Patients with a prior history of conditions being classified as adverse events, which include erectile dysfunction, ejaculatory dysfunction, reduced libido, depression, suicidal ideation, and gynecomastia were excluded. Eligible patients were invited to participate in the study, and written informed consent was obtained from the participants. Eligible patients were administered a 2-time descriptive questionnaire that was designed to assess the adverse effects. The survey encompassed items from the male sexual health questionnaire and the hospital anxiety and depression scale, depression subscale, to qualify these effects, as well as questions evaluating demographics, social and medical characteristics, including chronic illnesses, smoking history, and exercise routine. Inclusion was also made for patient-reported adverse effects. Initially, the questionnaire was interviewer-administered and subsequently telephone-administered at an interval from 6 weeks to 6 months after commencing 5 ARIs. Patients who were not able to be followed up via telephone were censored. The endpoints include both primary and secondary. The primary endpoints were the change from baseline to interval follow-up from week 6 to month 6 on the male sexual health questionnaire, erection, ejaculation, sexual desire scores, as well as the hospital anxiety and depression scale, depression subscale score, and the development of gynecomastia. Secondary endpoint was the change from baseline in personal stressors experienced at an interval from week 6 to month 6. So in terms of results, 94 patients were recruited. However, 14 patients were lost to follow-up, and a total of 80 participants were finally included in the study. The mean age of the participants was 65.8, with a standard deviation of 7.5 years. Of the 80 patients included in the study, 8, which was equals to 10%, self-reported adverse effects related to 5 ARIs. Erectile dysfunction was reported by 2 patients. In 1 patient, this adverse effect was experienced after 3 to 6 months of commencing dutasteride, and its severity remained the same with continued usage of the drug, and it did not result in non-compliance. While in the other patient, this adverse effect was experienced within 1 month of commencing dutasteride. It's actually worsened with continued usage and resulted in non-compliance. Other reported events included drowsiness, bloating, and insomnia, and constipation. However, these latter effects have not been reported in other studies as recognized adverse effects and cannot be explained by the pharmacology of the drug. No signs of depression were noted in patients taking 5 ARIs up to 6 months. The mean HADS-D score at baseline was 2.66, with no significant change in the post-baseline score, which was 2.5, with a p-value of 0.24. For the erection domain, there was a statistically significant reduction or worsening in the erection score from baseline 34.08 to 33.26. There was no significant change in the ejaculation and sexual desire scores. A clinical relevant threshold for the change in the male sexual health questionnaire erection domain subscale has yet to be determined, and the magnitude of change in the erection domain compared to baseline was considerable and was clinically correlated with 2 patients self-reporting erectile dysfunction as adverse effects. The reduction in the erection score was independent of the type of 5-ARI used. With dutasteride, the erection score was reduced from baseline 34.3 to 33.6, and finasteride resulted in a reduction from 31.6 at baseline to 30.1. 2 out of 80 patients reported gynecomastia that were on dutasteride. However, this was not statistically significant with a p-value of 0.63. The proportion of patients who experienced personal stressors was lower post-treatment compared to baseline. This positive result could potentially be related to the likely improvement in their LUTs with 5-ARI use, despite the negative effect on erectile function. So in conclusion, this study showed no association between 5-ARI and the onset of depression and gynecomastia within 6 months. 5-ARIs are associated with a reduction in their male sexual health questionnaire erection score within 6 months of therapy and may be correlated to the onset of erectile dysfunction. Due to the early reduction in the male sexual health questionnaire erection score, that is within 6 months, it is likely that this is actually correlated to the drug and not to the natural sexual decline in erectile function in men. A limitation of this study was the duration of 12 months, with the longest interval follow-up being 6 months. Hence, the long-term adverse effects of these medications could not be evaluated. These are my references. Thank you all for your attention.
Professor Aiken has a question.
Congratulations. A question though. The change in score, the MSHQ score from 34.08 to 33.26, you said that was statistically significant. Was it clinically significant?
So,
whereas I'm aware of the SHIP score, this is not a score that I'm familiar with. And the question is that slight difference in scores, does it really matter? Is it clinically significant?
It was statistically significant in terms of there's not yet a standardized threshold in what it would be clinically significant in the change in the scores presently. But it did result in 2 patients in this cohort actually reporting erectile dysfunction as a side effect. But the change in the score there's no threshold as yet as to what change would be clinically significant.
I just want to ask one question, because I made a comment that the fact that the erectile dysfunction decreased after 6 months, there was a correlation or maybe association with the drug. But the point is that, do you have any information to say to me what is the normal decline of sexual function or the rate of sexual dysfunction in a normal patient or patient who are BPH and may have had some other treatment option apart from the drug? That you can justify your comment to say it's the drug responsible because it's a correlating symptom.
So just to clarify, so the question is if I have a timeline as to what the natural deterioration in erectile function is?
Sure. How can you be sure that it's a drug and not an age and time-related decline?
Yeah, some of us increase over time, like that. And you have some people decrease.
So my justification was the short time period. So 6 months is rather short to have such a significant decline in the erectile function. However, I'm not aware of a set timeline in terms of what the natural history of the sexual function is.
Have these patients like diabetic or hypertensive or other factors that may affect that erectile dysfunction?
Yes, so those were actually captured and was placed in the baseline table. So I did try to identify or account for factors that may be confounders. So hypertension, diabetes, smoking history.
With respect to the erectile dysfunction?
No, so there was still no correlation between the patient demographics who were still, association, sorry.
Yes. Sorry, I have a question. Very nice study, and definitely my area of interest. Are these drugs available free of cost to patients on the NHS?
Yes.
Okay. How did you measure compliance with therapy?
So compliance that was measured on the questionnaire, there were questions to say how often the patient took the medication. They are prescribed to be taken daily. So the options were daily, at least 3 times per week, less than 1 time per week. So those were accounted for in terms of compliance.
So did you present that data?
The frequency? No, I didn't.
That would be important. I mean, efficacy is related to that adverse effect. So that would be important. And whether they were taking multiple medications, because polypharmacy is another issue with compliance.
I did account for medication, for other medications.
I had a comment, very nice study as well, I liked it. There was a little bit confusion in my head. You said you have baseline assessments on all of these, and then you have one more assessment, or you have one at 6 weeks and one at 6 months and beyond?
The time period varied, so it would be based on how long the patients have been on the medication. So the follow-up interval was at 6 months, but the 6 weeks would capture the patients who would be in the latter half of the data collection.
So you did only 2 assessments?
Correct.
One baseline and one anywhere between 6 weeks and 6 months?
Yes.
Okay. So again, going by what Professor Gosling-Williams was saying, 2 things important to account for is adherence, how well they are taking the medications, because that would affect outcomes, and length of time. I know you spoke something to that, but I think when you really bring this paper to publication, you want to be very clear, because I suspect, and I don't know, I'm not a urologist, that some of the, are there any side effects that you might expect more with time, depression and so on? I don't know how quickly you expect some of the side effects.
So most of the other studies that look at these adverse effects, the minimum timeline was 18 months to account for depressive side effects. So the short time period of this study being 6 months would not account for the long-term effects seen with these medications.
Outcomes may be visible. Some of your adverse events would be visible sooner than the 18 months.
Yes, like the sexual side effects.
Okay. Yeah, thank you. Great.
Thank you.
Thank you very much. So I'm going to now invite Professor Maxine Gossel-Williams in her capacity as Deputy Dean of Graduate Studies to make a comment.
So good afternoon, everyone. I came here this afternoon only to represent the dean in my capacity as deputy dean of graduate studies and got dragged into judging. But I'll have to tell you that I don't think my scores are going to help much because I think you all did very well, very well. I was totally impressed, and I have to say I'm a little disappointed with surgery because in all the years that I've been at this university and operating at the level of research, and Dr. Morrison knows that I have reached out quite a bit to the department, I did not know that all of this display was going on. And this rich research is not being shared with the rest of the faculty. So now that I've been sensitized, I'm going to ensure that next year this room is full. And even if it means bringing the principal to see what is happening among our students. And I'm going to be even more optimistic about the publications that are going to come out. Because all I saw today were DM students who were fully engaged in their research and bubbling to write and report and continue with the research. So congratulations, Department of Surgery, on the work that's going out. And I look forward to more of this. Thank you.
Thank you so much, Prof. We're now going to invite Ms. Karen Kelly from Ferrin to make a presentation.
While he sets my presentation up, I just want to say thanks to the department for including Ferrin in this event. We're very happy to see its return. I know it hasn't happened since COVID, and we're happy, of course, to be a part of the event. So my name is Karen Kelly-Reid. I'm the Regional Sales Manager for Ferrin Pharmaceuticals. And with me is my colleague, Kimon Fraser, recently joined our team. So I just want to take a brief moment to introduce Ferrin to you. We are not a new company, but certainly the specialties, especially our urologists, gastroenterologists, OBGYNs know us. We really started our operation in Jamaica fully in 2014. And I'm very proud to say that we have done some research with some of your DM students over the years. And I'm really happy to see this research day and hope that some of our products can be researched. Again, we want to re-energize that program that we started. So Ferrin is not new. We were founded in Sweden in 1950. But we're a privately owned, research-driven biopharmaceutical company that's currently headquartered in Switzerland. So we are very big on research. Our excellence is in peptide and endocrine research, and we're committed to building families worldwide. We're known for our fertility portfolio, but we have a very nice portfolio of products in urology, gastroenterology, and endocrine research. At Ferrin, people come first. That's our motto. Sorry. And our mission at a glance is really about helping people live better lives. This is our portfolio of products. And as I said in my introduction, we have had some research done. I'm looking at Dr. Morrison, the very first research that was done with our prostate cancer drug, Firmagon, in any Caribbean population was done right here at the University of the West Indies. And we're very proud of the results. And in fact, this led to this product being included in the National Health Fund in Jamaica. And we have used the data from here to have the product in other jurisdictions. The results of Dr. Morrison's study on that product. In our reproductive products, Our obstetrics products, I remember a young Omar Wellington, who is now a consultant at Victoria Jubilee Hospital, doing research in his DM program on our duratocin or carbitocin to prevent postpartum hemorrhaging. And that product is now in the VEN list as a vital, essential, and necessary product. But the data from Victoria Jubilee is what helped us to have access. And later in my presentation, you're going to see the impact of that worldwide. And I look again, let me see what other product. I heard Dr. Matthews' presentation about colon cancer. And we have our PicoPrep, which is a product that is used to screen for colon cancer. It's well used across the world. And so these are opportunities that we see to collaborate with the university in research. I just wanted to say that we're a science-driven organization. We have a strong record. Our focus is in reproductive, gastro-urology, and uro-oncology. We have 2 new products coming in uro-oncology, one for bladder cancer. So Dr. Morrison, if you're thinking about doing any research or you have any residents that might want to look at that, we are very open to that. I am going to skip over a few slides, but just to say that study that I referenced with Omar Wellington, with our carbitocin, the Sustainable Development Goals are to reduce maternal mortality to at least 70 per 100,000 deaths. For us, 70 is too much. And Ferrin conducted the largest ever obstetrics trial with over 30,000 patients with our room temperature carbitocin. And this was a study, and I'm going to share with you how the world announced the results of that study. This was such an impactful study that showed that in countries, especially sub-Saharan African countries where the temperature, the cold chain of the product of oxytocin was compromised. You know, in Africa, you have a lot of places that don't have refrigeration, so they were desperately needing a product, a urotonic agent that would reduce maternal mortality after delivery, but that was safe and could handle heat, that was heat stable. And so tying back to that study that was done with that DM student, Dr. Wellington at the time, and this, the results that came from that study, this is why our carbitocin is now a vital, essential, and necessary drug in almost every jurisdiction. So what we're saying is that what may have seemed like a small little study done in Victoria Jubilee in Kingston has worldwide impact. And similarly, the research that Dr. Morrison did with Firmagon, we look for opportunities to collaborate with the university. We're very big on research, and I'm really happy to be here today. And my final word is a big congratulations to the 10 persons who presented today. I thought your presentations were fantastic. And you all are to be congratulated for such a wonderful presentations. So that's my words for today. Thank you so much for the opportunity. And we have some refreshments outside that we invite you to partake of. Thank you.
So our residents did so well. Our judges are sitting and collaborating and adding up scores and tallying. But let me just also echo my congratulations to all the residents. I'm really, really proud. And really, really proud. You did very well. And I hope this inspires our other residents, younger residents who are in the program to do likewise for next year. I mean, we want as many persons submitting. We may not be able to accommodate everyone, but more persons doing the research and certainly aiming to present and publish, because I'm pretty sure that you enjoy the experience to present here today. All right? So we do have a prize for the best presenter, and we looked at various things. We looked at the impact of the topic, and certainly whether it's local or international. We looked at the research design and methods utilized. We looked at overall presentation style and skills. And I'm going to allow both Professor Aiken and Professor Asnani to come forward and tell us about their experiences her experience as a judge here.
Ooh. Hi, everyone. It's great to be here. And I think it's a good idea. I don't think Belinda thought of it when she did it, but she actually got 2 GPs to score, even though she probably got us to score because she thought we know research. Marvin definitely does. I know a bit, not as much as him. He's been my mentor over the last 20 years as well. But I was blown away. My good friend Eric Williams has always told me about a lot of the work that he used to really love doing research in this department as well. And I've heard over the years some of his projects, but what I saw today was just amazing work. And before I came here, I had gone through all the abstracts, and I thought the novelty of the topic and the impact of the topics would have been just 5s for everyone, because it's just amazing work that you guys are doing. And we at CARE, which is the Caribbean Institute for Health Research, where Sickle Cell Unit is situated, we end up seeing a lot of resident research coming to us, you know, and I am amazed that this department has probably done some of the most impactful work, which means your heart is really into it. So it's, you know, fabulous. It was great to be here, and if I say that I understood most of the work, then, you know, you really did great in your presentations as well. As a result, Prof. Aiken, you're all his kids right now since his HOD, so he wants to recuse himself from marking, but the 3 of us, Prof. Gossel Williams, Prof. Reed, and myself, we did mark. And can I tell you, to say one person is to get this, this award is very, very, very difficult because you are all very close to each other's marks. There were some presentations which were just not as effective, so let me not all be flowery. Okay, they were, and I think it was the presentation styles. I'm not sure how the abstracts were asked to be written. I don't know if you just said we're going to have this evening and so present an abstract. The presentations for some of the abstracts left a lot to be desired, but a lot of points were cleared in the oral presentations. Really, I think for all the presentations, they were quite much cleared. I want to say 2 things. I'm not sure why you guys are doing research. Is it because you're all in the DM program and you have to do research? You don't have no choice. That's a good reason. And I, like all of you, I'm a medical doctor, and that's what I've wanted to be since I was, since I had my senses. I probably got them at age 1. Probably since I know myself, 4 or 5 years of age, I wanted to be a doctor. So that's what I am, a medical doctor, but ended up taking a job at the sickle cell unit because, you know, for whatever reason, went there to see patients. And in my days, 32 years ago, when I finished med school, Rajiv is here, research was a dirty word. We never wanted to do it, like what the heck. So when Marvin asked me to join the sickle cell unit, I went there to see patients. And I had no interest in research. So for me to stand here and be looking at others' research work is really a little bit amazing. But I have realized over my years of working with patients living with sickle cell disease and doing research is that it's great to be a fabulous clinician, but because of what you bring to the patient in front of you and to their families. But as a researcher, you are really managing your patients from another level altogether. I hope you understand that and remember that when you go out there. From here onward, research must be a part of your being. Anybody who comes to this university, goes through a postgrad program especially, must realize the impact that good research can have. Prof. Aiken made the point, you know, so many of the projects here being presented are practice changing or potentially practice changing. He named 2 or 3. I thought all are potentially practice changing, and that is phenomenal. It takes a long time really for research to show impact in practice, but my research also has been developed through years of just seeing patients, seeing what I really want to find out some answers to, and going ahead and trying to get some answers through research. So I want you to remember the importance of being a clinician scientist for the rest of your working days and even thereafter. All right? It's critical. You are growing the field and you're really, really helping patients. Might seem a little bit indirect at a much broader level that can impact public health and global health, etc., in your areas of interest. So congratulations on great work. I know you don't really want to hear all of this. What you want to know is who won. And, oh, looks. Dr. Jason Hope, orthopedics. Where's Dr. Hope? Excellent work, Dr. Hope. I don't know, the marks are really, really tight, really, really tight, but you have taken the mantle when the 3 people scores, the 3 of us scores got added up, then you are the winner, just by a bare margin, which shows that so many projects were excellent, excellent. So, you know, we used to hear, when I was growing up, we called orthopods just, you know, people who come there with their big selves and just pull and push and tug and thing, but this, you're showing something else here, so amazing work, congratulations.
Colleagues, I am sure that we are extremely proud of our residents. The presentations were spectacular. These presentations could have been given at any international forum or conference and would have been of a very high standard. And I feel proud this afternoon as department head to know that we have residents who can produce this level of caliber of work. I can tell you the judges, it was exceedingly tight. I think all of you were excellent, and we're seriously considering, and I'll negotiate with Dr. Morrison if we can't find a prize for second and third place, because the differential between the first, second, and third persons were really, really tight, and all the presentations were excellent. So it is my pleasant task as department head to call Dr. Jason Hope to the podium. Cameras. I need paparazzi. Colleagues, I won't keep you long. I know everybody is hungry and we've had a long afternoon, but it would be remiss of me if I did not thank Dr. Belinda Morrison and her team for pulling off this research afternoon. You know, when I joined the department, we had this as a yearly event, and I know that it fell off the wayside for a while, and it's something that I really wanted to reinstitute, and I asked Dr. Morrison not all that long time ago to pull this off, and she did so immaculately. And so I want to thank her and her team. I want to thank Miss Laurel Bennett. in the Department of Surgery for giving her the administrative support that was necessary. I want to thank our judges who did a splendid job in judging this afternoon. I want to thank our Deputy Dean for bringing greetings and saying a few words on behalf of the Dean. I want to thank our sponsor, Ferring, without whom this event would not be possible and who is going to feed us shortly. I want to thank MITS for the IT support and for allowing an online